Hi everyone, my name is Nellie Figani and I'm a physiotherapist from Canada. And on behalf of the ICS Physiotherapy Committee, I would like to welcome everyone to ICS 2021 Melbourne Online. We meet today on virtual platform. I would like to take a moment to acknowledge the importance of the lands we live, work, and gather on. This session is called the Physiotherapy Forum, and we are pleased to welcome all the delegates watching. Please use the comments functionality to say hello and tell us where you're from. This is where you can also ask questions and participate in the discussion. If you're not watching live, you can still post questions after the session and the faculty will have a chance to respond. We have a very esteemed and highly regarded panel of speakers and moderators who are presenting for us today. Before we begin, I would like to thank Helena Frawley and the local organizing committee for all their hard work and contribution for today's session. I would also like to thank Heather Moki, who is our Physiotherapy Committee Chair, who has worked tirelessly to organize this session. I'd like to draw your attention to a pre-recorded video that you can also watch in addition to this live session that can be found at the bottom of the physiotherapy page. The presenter is Rebecca Das, and her topic is overactive bladder and the nervous system sensitization. So be sure you don't miss it. So it's unfortunate that times are such that we can't be face-to-face this year, but this year's session is very, very special. We also have some fun things planned. So you can join us at the ICS Live Lounge during the break and after the session is completed to meet virtually and chat. So you can follow the link to the live lounge that can be found below, and you can follow the steps to create an avatar. And once you're in the live lounge, you can use the cursor to move around and gather close to people, where at that time your webcam and audio become live and you can chat. So make sure you come to the live lounge and please say hi. I'd love to catch up or meet you. Now, this is a very special year because we're celebrating the 20th year anniversary of the Physiotherapy Forum. So at the ICS meeting in 1985, there were only 2 physiotherapists in attendance, so Joe Laycock and Dorothy Mandelstam. At the ICS in 2000, Marika organized a meeting about pelvic floor education and invited about 12 physio members of the ICS. Since then, a forum has been held each year and hosts on average of about 150 physiotherapists from all over the globe. The forum encourages new physio members to join the ICS, is great for networking, and encourages research and the presentations of research findings. We welcome anyone that is new to this session and hope to continue to see you in the years to come. For those of you who have attended in the past, I'm sure you would agree with me that this is an amazing opportunity for us as physiotherapists or anyone interested in physiotherapy to network, enjoy high-level presentations from emerging and established researchers and clinical leaders, and most of all, have lots of fun. I know personally I've developed lifelong friendships and have some wonderful memories that I will cherish. So before we start our session, let's watch this short video in celebration of the 20th anniversary of the Physiotherapy Forum. So grab your drink of choice. Mine will be a glass of wine. Depending on what time of day it is in your country, it might be coffee for some, and we will celebrate years of learning together, collaboration, growth, and friendship.
Yeah. Nope. And thank you to everybody for joining us. And what a wonderful video we got to share with some very familiar faces and some new faces that hopefully we're going to continue to make in the future years. I know it's been a hard not to be together in person, but glad for all the efforts that have been made to be here today. A big thank you to the ICS staff, to a lot of the faces we know, Jenny and Avincia, and a lot of the behind the scenes that we don't know, Dan and Dom and Roger and Rob and any of the people that I have forgotten. These are some really amazing people, and without them we would not be here today, so we really appreciate all you do. Thank you. Another thank you, as Nellie said, to the localizing committee and Helena Frawley and all the efforts. We are upset that we're not down under with you, but appreciate all the time and efforts that you made to get this program to being top notch. I'd also be amiss if I didn't take a minute to acknowledge so much of the physiotherapy committee. I mean, during COVID time, it's been hard. And of course, we have not been able to do all the things we'd like to do, but we're still, plugging along, getting some good things done. We do want to thank the time. We have 3 people stepping down this year if they've completed their time on. The first one is Adelia Lucio, and then we also have Paula Guadalajara Martinez, who has not only been on the physiotherapy committee, but has served on the Physiotherapy Institute. And last but not least, we have Cristina Naranjo Ortiz, who's been on both the physiotherapy committee and represents the physiotherapy in the Board of Trustees. And she is ending her term coming up this next week. So we thank all of them for their time and efforts. And we welcome our new staff from the Physiotherapy Committee to Marie Pierre-Sier and Heidi Mustorf Steinhauser. We look forward to working with you and see what we can create in the coming years. Once again, a big thank you to Nellie for all her time she's put into the forum as well. We're lucky to have her, and we get her a little while longer. And last but not least, I'd be amiss if I did not, say that 20 years and all the special things that have gone on 20 years. And there are so many people that have brought us to this point. And like, when I think about it, I actually get a little emotional because there are so many people who fought for physios to be part of these things and for research standards and clinical application. And we're so lucky for all those things from back in 1985 to look where we're at now in 2021. And so obviously we cannot celebrate the way we want to. So this next year, we're just going to continue to celebrate this 20th year, and hopefully we can all get together in Vienna. As I said, there are too many people who've been such impacts in the ICS and in the world of physiotherapy that, we can never repay for what they've done, but we all need to gather a little bit of that energy to continue to move forward and see what we've accomplished and what we continue to do. We are lucky that we are able to collaborate in this wonderful forum and this group of ICS with all the doctors and the nurses and other medical professionals. So just look forward to a lot of fun in the future and this next year as we look forward to celebrating the 20th year all year long. And stay tuned for more fun. Thank you.
Kia ora, Oh, sorry. I leapt in. It's my usual way. Kia ora, my name is Jean Hay-Smith. I'm speaking from Aotearoa, New Zealand. So welcome to this session where we discuss the case for biofeedback in women with stress-predominant urinary incontinence. And our question is always, usually, sometimes, rarely, or never. So my name, as I say, is Jean Hay-Smith. I'm a professor of rehabilitation at the University of Otago in Aotearoa, New Zealand. And I've got a very long-standing interest in Cochrane reviews of pelvic floor muscle training interventions, including pelvic floor muscle training with biofeedback. So before we move on to the presentation proper, I just want to say that we have no conflicts of interest to declare as a group. I do want to say thank you to ICS for paying my conference registration this year. And thank you for inviting me to participate in the many things I've been invited to participate in this year. So our first panelist this morning or evening, depending on where you are in the world, is Doreen McClurg. Doreen is a professor of pelvic floor physiotherapy at Glasgow Caledonian University, and her main area of research is pelvic floor dysfunction in the neurological population. So Doreen, you were one of the main investigators in a recently published trial called the OPAL trial that was designed in response to a call for research that investigated whether more intensive pelvic floor muscle training interventions were better than standard pelvic floor muscle training interventions for women with stress urinary incontinence. So what we're wondering is, why choose biofeedback as a way to perhaps intensify or make more intensive the therapy that is pelvic floor muscle training? And why was it thought that this might be better than pelvic floor muscle training without biofeedback?
Good evening, Jane, and thank you for the question. And good evening, everyone from Northern Ireland. Indeed, yes, we know that there is evidence in the literature to say that more intense physio brings better outcomes for the patient, but how we actually intensify the physio is less well known. And indeed, because of staff restrictions, costs, etc., it isn't always feasible to have more face-to-face contact with physios. But looking at the Cochrane review, they were equivocal in that quite often the research that had been done, the groups, if you like, that had the biofeedback also had more time with the physios. So from the evidence, we couldn't actually say whether it was just the additional of the physio as well as the biofeedback made that group more improved, better than the standard care. So it's really important that biofeedback, we know, improves outcomes. And if it does improve outcomes, it may be more achievable. And it also may help with such things as motivation, efficacy, for contraction, etc. So what we thought we would do would, undertake this trial where we were really sure that both groups got the same time with the physios. And we want to make sure then if the biofeedback using the device and being able to use the device at home actually helped improve outcomes as well. So we really needed a much better test to say whether pelvic floor with biofeedback was better than pelvic floor muscle training without it, especially as most standard physio did give us additional physio input as well. So we have to wait and see what the results of the trial, which has already been published. Yeah. Thank you, Jane.
Thank you, Doreen. One of the things I think too, I seem to remember, and it was that a lot of those trials also, not only did some groups have more time with the physiotherapist, but I seem to remember too that there were different pelvic floor muscle training programs sometimes in both the groups. And so that made it more difficult to tell what the effect of the biofeedback was as well. So let's go on now to actually talk to Professor Suzanne Hagen. Suzanne is a chartered statistician and Professor of Health Services Research at the Nursing, Midwifery and Allied Health Professional Research Unit at Glasgow Caledonian University in Scotland. And her research has focused on pelvic floor muscle training for both urinary incontinence and pelvic organ prolapse. So Suzanne, you were the lead of the OPAL trial, a very large randomised trial by physiotherapy standards, investigating the effectiveness of pelvic floor muscle training with biofeedback versus pelvic floor muscle training alone for women with stress-predominant urinary incontinence. So who was included in this trial and what were the findings?
Thanks, Jane, and hello everybody from Ayr, which is south of Glasgow. Yes, so it was a really large, pragmatic, multi-centred trial that we carried out across centres in the UK. So we included the 600 women across the 23 centres, and those women were randomised to the two groups that you'd mentioned, the PFMT alone or the PFMT plus biofeedback. The biggest group were those who had stress-predominant mixed urinary incontinence at 61%. And the women were typical of women that would be attending pelvic floor physiotherapy in services across the UK. The mean age was 48, a BMI of 28. And very importantly, we chose a primary outcome measure for this trial that was really going to be important to women, that mattered to women. So we used the ICIQ UI short form, which incorporates not just frequency and amount of leakage, but also how bothersome that it was to the women. So that was really important, that patient-centred outcome was our primary. And then we followed up the women for 2 years, a long period of time, from the time they'd started taking part in the study. And the biofeedback protocol, I think, as Doreen mentioned, included both clinic and home biofeedback. So in that group, in the biofeedback group, they received biofeedback when they went for their appointments, and they also had a device that they used at home in between appointments. If I just move on just to say a bit about the findings then. So across the board, we were very surprised to see the consistency of the findings that we had. There were no differences between the group and the primary outcome, but also across any of the secondary outcomes, and it was very clear that we were seeing the same pattern across the outcomes and across the different time points that we'd measured in the follow-up. So our conclusion was really that we had done a robust and generalisable trial, and really we found no difference of routinely adding biofeedback to the protocol for women with stress urinary incontinence.
Thank you, Suzanne. And I've just got a quick question before we leave this slide. And I know we'll get to question time later, and it might well be a question somebody else is interested in. I know the primary endpoint was that 2-year follow-up. Did you actually, in this trial, measure what people's outcomes were when they finished treatment? So I know that wasn't the primary comparison that you were making, but just out of interest, was there any difference at that point?
No, so not only no difference at 2 years, but no difference at the earlier time points immediately after treatment either. So as I say, everything was very consistent in the pattern of the results.
Right. Thanks, Suzanne. That's great. So our next speaker is Christine Homsi-George-Ferreira, and Christine is a women's health physiotherapist and associate professor in Sao Paulo in Brazil. Christine, I know that you're involved in updating the existing Cochrane review of biofeedback. We know it's well out of date. It was published in 2011, the previous version, and we haven't finished doing that update yet. However, I understand that you can already see that there are important clinical questions about biofeedback which we may not have much trials-based evidence for. What might some of those evidence gaps be that we still have?
Good evening, Jean. Good evening, everyone. I'd like to thank you and the ICS organizing committee, especially to the local committee in Melbourne, for the opportunity to participate of the ICS Physiotherapy Forum 2021 to discuss such an important topic for women's health. Well, most trials found are for stress urinary incontinence or mixed urinary incontinence in mid-age women. We have less trial data about urge predominant urinary incontinence or urgency urinary incontinence. Quite a few trials have an upper age limit. We probably know less about response in both younger and older women. Around 30% of women are not able to contract correctly their pelvic floor muscle, and most trials excluded these women. However, it is quite common to hear therapists say that women who might benefit most are those who find it harder to contract their pelvic floor muscle. It seems we don't need more trials testing the effectiveness of biofeedback for stress urinary incontinence in mid-age women. Any further research would be better to address clinically important questions without much data available, as the effect of biofeedback in women unable to contract their pelvic floor muscle.
Thank you, Christine. One of the things that's interesting then is this idea about whether you are or aren't able to contract your pelvic floor muscle. When we're thinking about that clinically and think about something like the modified Oxford scale, What sort of grading on that modified Oxford scale would you say covers that finding it hard to contract group of women?
0 and 1 in the modified Oxford scale. And we would have as an outcome measure, the goal, women to achieve 2 or more. And even we can have both outcome measure, 2 as the ability to contract their pelvic floor muscle, and 3 or more to contract correctly with component of lift and squeeze.
Great. Thanks, Christine. That's an interesting thought about what might be important to measure in that group. So our final speaker is Ana Carolina Nochidi Fernandez, and I'm delighted that Carol, as she calls herself, is with us. Carol's a physiotherapist with a particular interest in women's health, and she's currently a PhD student with Christine there in Sao Paulo in Brazil. And so Christine's whole PhD is on the subject of biofeedback. So you're involved, Carol, in updating the Cochrane Review, but one of your other studies is a qualitative study. So tell me the reason for that study.
Good evening. It's lovely to be here with you all today. Introduction and discussion of RCTs and systematic review often mention that might be a clinical reasoning for physiotherapists to choose to use biofeedback while treating women with pelvic floor dysfunction. And this clinical reasoning could influence their clinical practice. So clinical reasoning is an empirical study object that varies according to context due to economical, cultural, social, and religious factors. And this might vary from country to country. So this empirical study object better understood while using qualitative studies. And to date, there is no qualitative study aiming to understand the relationship, the clinical reasoning behind the clinical practice. So we aim to understand when and how pelvic floor physiotherapists decided to use biofeedback while treating women with pelvic floor dysfunction. And we are not only identifying components, but also trying to find the relationship, the relationship between these components. Therefore, we are conducted a qualitative study using grounded theory methods, and we have a two-phase data collection study. Phase 1 is an online form that it can be assessed using this QR code. And phase 2, it is an online semi-structured interview that we proposally select participants from phase 1 to phase 2. We are recruiting physiotherapists from different countries with several levels of experience using biofeedback. So if you are one of them, please, and you speak English, Portuguese, invited to use the QR code for one questionnaire.
Thank you, Carol. It sounds like an exciting opportunity possibly for some of those listening who are physiotherapists using biofeedback in their pelvic floor rehabilitation practice, who might be interested in contributing their thoughts about why biofeedback is an important part of physiotherapy practice and when they do and don't use it and why that is. So hopefully, possibly there's some people listening who'd like to tell you more about that.
Yes.
So we We come to the point now in the forum where we have about 5 minutes or so left for question and answer time. And just while those are coming up in the chat, I just want to quickly summarise some of the things we've heard, because these might be some of the things you want to ask questions about. So from Doreen, we heard that the original Cochrane review was unable to determine, because there was this confounding between amount of contact with physiotherapists and differences in the pelvic floor muscle training programs, if in fact it was the biofeedback that was associated with the slightly better outcome that was seen in that group. Suzanne summarised the findings of a robust, large randomised trial that didn't find any benefit 2 years later in the ICIQ SF for important continence outcomes when biofeedback was used compared to no biofeedback. Christine's pointed out that there are some groups that we have less information about, like older women, perhaps, women who find it more difficult to contract. And so there are potentially some continuing important gaps in the literature. And Carol's telling us about her PhD studies, including a qualitative study that might help us explore why some of those gaps in the literature exist and what we're thinking about them. So, for example, the use of biofeedback for women who find it more difficult to contract. So I'm just going to pause there and see if Nellie or Heather have any questions that are coming up in that chat function that panelists can answer.
Thank you so much, Jean. Actually, there's some great comments in the chat. I've tried to pull out some of the questions. There's a question from, I apologize if I don't say your names properly, but Barbell Jinger. And sorry, maybe I missed that. Is this a topic on special biofeedback tools such as EMG biofeedback or an all kind of biofeedback forms?
So I think that's possibly asking about Carol's study. Carol, in her qualitative study, is interested in talking to physiotherapists who use whatever sort of biofeedback, because we know, I'm sure, that it varies around the world. So Carol's interested in any sort of biofeedback. I'll let Doreen or Suzanne answer the question about what sort of biofeedback was used in the OPAL trial.
So in the OPAL trial, it was EMG biofeedback that we used with an intravaginal device, primarily connected through leads, and towards the end it was through Bluetooth, but it was the EMG biofeedback we were using, both within clinic and then with small handheld units at home.
Thank you, Doreen.
We have a question from Vincent, who's a urologist with us here today, which is great. What level of evidence in biofeedback in the context of pelvic floor pain for women with pelvic pain secondary to pelvic floor overactivity?
And that's a question I don't know the answer to. I haven't been working in the trials evidence about pelvic floor pain, but I'm going to open this up because I know we've got some incredibly experienced physiotherapists here in the panel, and I'm wondering if Christine or Doreen perhaps might have something that they'd like to offer.
Hi, sorry, no, I have no experience or don't know the evidence within the pain area.
Well, I don't know either if there is any evidence related to this topic. I think this would be really interesting, but I don't know. I don't know any RCTs showing good evidence related to this topic.
I'm thinking that later in the physio forum, we have people like Helena Frawley, who I know specialises in pelvic pain, and she might have a better handle on the evidence. But I'm also wondering about Heather and Nellie, who are our chairs for this forum. Perhaps they have thoughts about this.
I'm not aware of any research in this area, but certainly interested in learning more.
Mm.
Yeah.
Mm. So I'm sorry, Vincent, it sounds like we don't have a good handle on the evidence on that one, and it may be because there isn't very much, and that it's actually currently based on evidence from clinical expertise, people who are working in this area more commonly and are accruing their observations over time.
Okay, so we have another question from Denise, and this is for Christine or the whole panel. How do you propose in moving the patient with weak or poorly coordinated patients beyond a modified Oxford scale of 0 or 1?
Could you repeat it, please? I didn't get exactly what she wants to know.
So if someone is presenting and their strength, their modified Oxford scale strength is a 0 or 1, how would you propose moving them forward to improving that seam change?
Well, there are some RCTs in the literature now proposing the use of feedback. Physiotherapists can use feedback to teach women how to contract their pelvic floor muscle. If they have 0 or 1, we have some evidence from RCTs that it's possible for them to achieve 2, more than 2 in the modified Oxford grading scale, or more than 3 using this protocol of 8 weeks doing feedback with instructions for women to learn how to contract their pelvic floor muscle. We have some evidence also related to electrostimulation, including a new trial that is about to be published, showing that we can use electrostimulation also with good results. But we sure need more RCTs on this topic, and including studies investigating biofeedback.
Thank you, Christine. This is a question from Cheryl Ludwig. Thoughts on how the choice to use biofeedback in relation to Nishi's behavioral change model?
Sure. So I know that Doreen and Suzanne and myself, who were all involved with the OPAL trial, we used Susan Mickey's behaviour change taxonomy, the 93-item taxonomy. And that was a very large part of our intervention development for the OPAL trial. And one of the things was that in both groups, both the pelvic floor muscle training and the pelvic floor muscle training with biofeedback group, we had what we called a set of gold behaviour change techniques that were mapped to that taxonomy that were being used by the physiotherapists. And we had a set of optional ones as well that we thought might be appropriate and physiotherapists might select from as appropriate according to individualising treatment a little to their woman. In addition, of course, biofeedback itself is mentioned on Susan Mickey's 93-item taxonomy as a behaviour change technique. And we had a number of additional behaviour change techniques in and around the biofeedback. So, for example, one of the items on the taxonomy is about giving feedback on behaviour. So that meant that in the biofeedback group, the physiotherapists were giving feedback to women on the behaviour of pelvic floor muscle training, but they were also giving feedback on the behaviour of using the biofeedback home unit, for example, whether women were recording that or not in their diaries. I'm just going to hand over, I think, to Doreen or Suzanne just to comment really on what their sense was of how the physiotherapists in the trial got on with those behaviour change techniques, because my sense is a lot of them were already very familiar, like goal setting and things like that. But perhaps Suzanne and Doreen would like to add a little more about the behaviour change technique use in the OPAL trial.
Well, I suppose some of our original theory was that potentially using biofeedback was actually enhancing the behavioural change technique because the woman was getting better feedback and more motivation, etc., etc. But again, as you said, both groups actually had the behavioural change that the physios were actually trained to some extent to do. But a lot of these motivation things, as you said, Jean, were what physios do naturally. So it was talking to the patient, getting the patient to agree what their goal was, what was important to them. And also what was important was setting the target of their exercise regime as to what they thought they could do. And if they achieved their exercise regime, that was fine, but not making them feel like a failure if they didn't actually do it, and having a stop start and being able to make sure that they were motivated all the time and didn't feel bad if they didn't actually achieve what they did, or were rewarded and they did actually see an improvement. Because as you know, sometimes improvement can be really, really slow, and it's really the difficult bit is actually getting the patient to continue with the exercises, and using all these behavioral change techniques actually, I think, it really helped as well. I think it just brought it really focused to the physio, how important their role as a physio, as a motivator was.
I'm just going to ask Suzanne too, because I know that alongside the trial itself, there were other studies running. So Suzanne, do you want to fill us in about the other parts of that quite large research program, really?
Yes, sure. As Jean's mentioning there, so we did audio record some of the appointments where the women were being treated, which provided very rich data about what actually was delivered in the appointments, in whether the protocols were delivered as they had been intended. So we were able to see from, or listen to those, and figure out whether the checklists with the behaviour change elements had been delivered or not. We also interviewed, I was interested in hearing about Carol's study, because we also interviewed 26 therapists within the trial. So we've got some good data there about their experiences of it. And obviously we interviewed women as well who had taken part in the trial, a fairly big sample of women who were interviewed at the time points across the trial, as at the points where the outcomes were measured also. So a big longitudinal data set there. I was just going to add on to what Doreen was saying, that I do remember well when we developed the protocol and the focus group with the clinicians, and being struck by how a lot of the behaviour change skills were already there, but there are a few that possibly weren't, and I think it took the therapists by surprise when we were asking them to sell themselves as a credible source to the women, and that didn't come naturally to the therapists. And but they really took that on board, I think, and were upfront and were telling women, I'm an expert in this area and I'm here to help you. And it seemed to be one of the effective components of the protocol.
Mm-hmm. Great, thank you, Suzanne.
So we have a question here from the chat, and there's actually some really good chatting going on right now. So I'm going to try to kind of catch up and bring this to all. If I can just get it here for a moment. So the question, came back, and it was originally asked by Selkin, and I apologize if I butchered your name. What is your treatment option in stress urinary incontinence patients with zero muscle strength, or whom can't accomplish any contraction even with biofeedback? And then there's been a little chat going on. Julia Herbert point out that say we need to understand why they are considered the zero, grade 0 to 1. Maybe they're at the end of the normal scale of tone, of increased tone, and have nowhere to contract, or they're at the opposite end and cannot contract. For those, definitely stim will help. But for those with increased tone, other strategies will need to be more relevant. So if you guys could, discuss that and give us your point of view, and then we'll jump back to the chat.
Yeah,
Thank you.
Thank you, Jean. I would like to answer. So wonderful question. Thank you so much for this question. I think we need to learn much more about women who are not able to contract their pelvic floor muscle. And new studies, new research is really welcome. Trying to link and to make an association between tone and pelvic floor muscle function is really welcome too. But we lack more reliable tools to do this. We know that we need to develop more tools to evaluate this tone and to try to have more studies to make this association. Right now, we know that if we give instructions to women, part of a woman will be able to contract their pelvic floor muscle, even without any tool as a biofeedback. And we are not sure if biofeedback is the right tool to teach women how to contract their pelvic floor muscle, especially the manometer. If we use pressure, this device, not EMG device, we are not sure if this is the best option, because the reading can be related to abdominal pressure increase and not exactly of the pelvic floor muscle contraction. So right now, what we know that in women not able to contract their pelvic floor muscle, classified as 0 or 1, using the modified Oxford grade scale from an RCT conducted by our group, we have shown that it's possible for women to achieve the pelvic floor muscle contraction from grade 0 to 2 or 3 using only instructions. We had one group that received only instructions, and 18% of this group could be able to contract their pelvic floor muscle, but we have had a larger percentage of women able to contract their pelvic floor muscle when they received the feedback with vaginal palpation and instructions from the physiotherapist. And also we had a group receiving electrostimulation that had effective response. They could acquire the ability to contract their pelvic floor muscle, but a less percentage than if we compare it to feedback with vaginal palpation. So we need much more study, and we need to understand, I agree, the role of tone in relation to inability of women to contract their pelvic floor muscle.
I think that's a really interesting response, Christine, listening to you, because one of the things that's being suggested there possibly is how much skill actually resides in the therapist for actually what that therapist can feel through palpation, whether it's the tone in the pelvic floor, or whether they think there are deficits in the muscle, or trigger points, or whatever it is, that actually, and that ability to use what they're feeling to then really coach and teach really, really well, and potentially the power of that. So how much that skill in the physiotherapist maybe is more than we can wrap up in a bit of technological equipment. That's personal opinion. I don't have any evidence for that, but it was a reflection on what you were saying.
I really agree with you, Jean. I'm a great fan of vaginal palpation as an easy tool for us, for physiotherapists to use to teach patients about the pelvic floor muscle function, and also to access in our clinic practice. In our practice, we can use vaginal palpation to teach and to give good instructions, but we do need more RCTs showing that it is important to access tone too, and yes, that we can sometimes do down training if necessary for women to have a better awareness of their pelvic floor muscle, and then to evolve with other instructions, more specific instructions. I'm really waiting on great new RCTs on this topic to show us what we are able to do, but we really trust our ability, our skill as physiotherapists, and to really help women to facilitate a correct pelvic floor muscle contraction.
We have another question here from the chat, if it's okay if I jump in here, because this is all in line. This is from Chantel in Canada. Is it possible that EMG biofeedback was not a good proxy for their improved pelvic floor function, and therefore did not have much effect motivating the participants? So now we're kind of changing from the clinician role to looking at more the participants' motivation there too.
Yeah, I think this is a really interesting question because, of course, biofeedback is a recognised behaviour change technique. And so, you know, I don't think there's any question about that. The question is really, I guess, whether it was a useful way of helping women understand what their muscles were doing, and whether the feedback they were getting from that EMG biofeedback helps them engage with the exercises, helps them improve their pelvic floor muscle training, either performance of contraction or actually integrating that pelvic floor muscle training into their daily lives. Like, there's a lot more about pelvic floor muscle training than whether you have a correct contraction. That's the basis. But then, of course, you've actually got to do it. Exercise is a behavior as much as it is the physiologic process of, you know, hypertrophy in the muscle and things. So I guess the whole question is biofeedback enough? There's two parts. Does it help people improve their contraction performance? But then there's the whole question of, does biofeedback have any effect, therefore, on whether people integrate that pelvic floor muscle training into their daily lives and do enough of the exercise, the behavioural part, to get the effect? And I think Doreen referred to this, which is one of the reasons why women were given sort of biofeedback units, handheld units, to have at home in the OPAL trial, was the possibility that having that there as a prompt or cue in the environment, which is another behaviour change technique, might actually help women think more about their pelvic floor muscle training. And if they lack confidence in a contraction, maybe the handheld unit, if they had it there, could give them some of that confidence, and having more confidence, they might do more exercise. But Suzanne, maybe you could tell us, based on the OPAL trial results, whether there was any, I can't remember if this was measured or not, was there any sense that women in either group did more or less of the exercise? Like, was the exercise adherence any different between the groups?
It was, in terms of percentages, it was slightly higher in the biofeedback group, but not significantly.
Okay.
I think it was 50% maybe, compared with 43% in the way that we defined adherence for the report. So slightly higher, but not significant.
I don't know, Doreen, do you want to add anything into that about that question of whether EMG biofeedback was a useful thing to choose in terms of supporting motivation or exercise behaviour?
I think a lot of it depended both on the physiotherapist and on a particular patient. So although the physios, all agreed and were trained into how to use it, biofeedback, I think maybe sometimes they found it technically slightly difficult. There were some patients who really liked it and were, really happy to use it, and help, reminded them to use it, and they were able to see the contraction, et cetera, et cetera. And there was other patients who didn't like it and just thought it was a complete bother. So I think it really depends on your patient.
And it would be unfortunate, wouldn't it, if the biofeedback was a distraction away from the behaviour you want, which is someone to actually do enough exercises at home.
We have another question here from the chat, and it's asking, from Vincent, asking about, what about elderly women? Example, in an 80-year-old lady with good cognitive function and stress urinary incontinence, how successful in pelvic floor muscle training in the non-frail elderly?
Doreen, I seem to remember that Suzanne referred to the interviews that were done with the therapists. Can you remember what therapists said about age of women and whether they felt older women did or didn't do as well with the biofeedback?
From what I can remember, older women did equally as well. Wow. And quite a few years ago, long time ago, I did a survey of elderly ladies about vaginal assessment and all internal, and using biofeedback and touching, etc. And elderly women actually were as agreeable to have assessments used biofeedback as younger women. And I think it was just because if I had babies and et cetera, because I thought for younger women who were using tampons, et cetera, would be more happy than your elderly ladies, but the survey didn't show that at all.
And Suzanne, what was the age limit, upper age limit, if any, in the Opal trial, and what was the age range?
Yeah, you're testing my memory now. The average age of the woman was 48, and from what I remember, the standard deviation was about 10 or 11. So you're probably talking that most of the women were, were under 60, or round about that age. If I find the range, I'll come back to you. But so I think that we're not talking about a very elderly population taking part.
Well, that's probably where
we've come to our time.
Yes, that's where we need to wrap up. There's still some questions on the chat that the panel will go back and address later. So please keep any questions you have for this wonderful panel. We thank you for your time. And we're going to pass it on over to our next topic on bowel dysfunction.
Hello, my name's Angela Kera. I'm a physiotherapist here in Melbourne, working predominantly with functional bowel disorders and of late inflammatory bowel disease. And it's my absolute pleasure to introduce this evening, our next speaker, Paula Igualada Martinez. Paula completed a Master's in Women's Health Physiotherapy at Oxford Brookes University and has been the clinical lead for pelvic health physiotherapy services at Guy's and St Thomas Hospital, London, since 2007. Paula works with urology, urogynecology, colorectal, pain, and psychosexual teams, giving her a great insight into the advanced assessment and treatment of pelvic floor-related disorders. Last year, Paula started at Brunel University as a clinical lecturer in the Advanced Clinical Practice in Pelvic Health postgraduate course. Paula's main research interest is the effect of physiotherapy on pelvic floor dysfunction following childbirth. Today, Paula is talking about bowel dysfunction and physiotherapy management beyond the squatty potty. Thanks, Paula.
Hi. So thank you, Angela, for a lovely presentation. Good morning, good afternoon, and good evening, depending on where you are. And thank you very much for the Physiotherapy Committee for inviting me to speak here today. And this presentation literally is about, I'm just going to try to give you an overview of bowel dysfunction and its physiotherapeutic management. If you do have any questions, please do wait until the end or when we actually break out for our networking event. I'm going to say that it's the 20th physiotherapy anniversary, but it's my 10th anniversary with ICS. The first time I attended ICS was in Glasgow, where Jo Lycock got her Lifetime Achievement Award, and it was quite an inspirational and motivational conference altogether. So yeah, it's quite nice to be here today, actually. Anyway, so nothing to disclose. As I said, Angela and I talk from the perspective that both of us actually work with colorectal surgeons, which sometimes give us a deeper insight in bowel dysfunction. So the role of this presentation is to provide you a sort of overview about bowel dysfunction and its physiotherapeutic management. So before we start, let's just remind ourselves about what happens, why our continent, and obviously for us to be here sitting down, having a glass of wine like Nelly, yes, or a glass of coffee like Angela, you need intact musculature, yes, and that goes through the puborectalis and that lovely anorectal angle, and a good anal sphincter complex. Obviously, we need intact nerves, we need a normal rectal compliance, a good stool consistency, remember that Bristol stool chart, and normal cognitive function. So a combination of all of this makes sure that we are here sitting while not pooing ourselves. Whereas what happens when we actually want to empty our bowels? Basically, obviously, colonic activity propels the stools and rectal filling, okay? That generates an urge to defecate. And that rectal distension induces the rectoanal inhibitor reflex, which allows the internal anal sphincter to relax. And the external anal sphincter contracts. But that sort of process allows what we call anal sampling, okay? And make sure that you can see what sort of a stool or what is going on. Is it a fart? Is it a liquid stool? Is it actually a stool? Actually, do I want to hold on? Do I need to move away? Or do I want to sort of actually defecate? Because if you're in Australia now and you're just having coffee and breakfast, maybe your gastrocolic reflex is working and you might want to go and empty your bowels, yeah? And obviously for that to happen, the external anal sphincter and the puborectalis needs to relax. You also need increase in abdominal pressure and rectal peristalsis. So rectums have to sort of expel the stool. And, at the end, what happens is obviously the external anal sphincter closes after you have finished. And if I start thinking about patients, for example, that sort of nice closing mechanism is what a lot of women actually complain once you have had children. That's no longer like a quick, process that is more difficult, and it's more difficult to get clean, for example. What are the main, I just try to make it very sort of clear, what are the main sort of dysfunction that we treat within physiotherapy? And obviously we have bowel evacuation difficulties, the pain syndromes, the bowel control difficulties, incontinence, and the new kid in the block is the low anterior resection syndrome, where we are actually now starting to get our teeth on, yeah? And, obviously constipation, bowel evacuation difficulties. I normally, when I think about constipation, I think about functional constipation and secondary constipation. And functional constipation, obviously, we have a slow transit. And remember that a slow transit constipation refers to when the patient takes more than 72 hours to open the bowels, right? Whereas normal transit, someone will actually open their bowels within 24 to 48 hours, but they might find it difficult to empty because the stool is hard, for example, yeah? We have irritable bowel syndrome and constipation, and then remember that this is very important because, irritable bowel syndrome, in order to be called that, it needs to be an abdominal pain that is relieved by defecation, yeah? And defecatory dysfunction, this inertia, and what I mean is uncoordinated pelvic floor. We talk about anismus, when the puborectalis contracts upwards rather than relaxing, that might not be related to pain, for example, and then any dysfunction of the abdominal wall and the diaphragm. Whereas secondary constipation is your structural abnormality. So you might have a rectocele, you might have a rectoprolapse, perineal descent, maybe rectum intussusception, and solitary rectal also syndrome. And then you have your systemic, what actually can lead to constipation. So from a metabolic point of view, we obviously have diabetes, we can have hypercalcemia, hypothyroidism, for example, neurologic conditions like MS or your Parkinson's disease or your spinal cord injuries can give you secondary constipation. And pharmacologic, sort of, is the patient taking opiates, for example, or is the patient taking anticholinergics? So all of this will give you difficulties to empty your bowels. And I think it's very important to sort of say that most of the times these symptoms will overlap. So for example, you have someone with normal transit with difficulties because, they're taking anticholinergics. And what I mean by that is this might be your typical patient with urinary incontinence that as a management of the urinary incontinence decreases fluid intake, then you actually, the stool becomes hard. Remember that type 1, 2 on this Bristol stool chart, and then it's more difficult to empty. Whereas then you might have the patients that might have a slow transit constipation with a mixture of, defecatory dysfunction and a structural abnormality. So they might have a rectocele and this inertia, and then obviously they might have a slow transit constipation without not knowing. And then you have a rectocele, which is more difficult to empty. And then as a consequence, then you start sort of straining in the wrong direction, for example. So all of this will actually come together. From the pain syndromes, we have two main pain, sort of conditions or main sort of groups. We have the functional anorectal pain, and I'm talking about more in depth tomorrow at the workshop at the Physiotherapy Institute workshop. But we have the elevator on eye syndrome, the unspecified functional anorectal pain, and the proctalgia fugax. And then the functional gastrointestinal, obviously we have the irritable bowel syndrome. Remember that is actually, it's very important that, the patients are relieved by defecation. And then we have a new kid in town again with the centrally mediated abdominal pain, which was formerly known as functional abdominal pain syndrome. And I think with this group in particular, for example, I always ask the question, what comes first, the chicken or the egg? I think, for example, when we do the digital rectal examination and we observe patients, you might have that the patient had a history of anal fissure, anal fistulas, they might have abscess, they might have thrombosed hemorrhoids, they might have solitary rectal ulcer, they might have intussusception, they might also have neuralgia and coccydynia. So again, a typical case, for example, to have levator on eye syndrome will be that, for example, again, if we go back to that example where, someone for whatever reason stops drinking water, that's the easiest one, but someone is, or maybe I'll go with a difficult one. So someone with a rectocele that is the struggle to empty the bowels, right? And then it starts straining, it doesn't empty, your rectum gets full of a stool, and then you, for example, empty your bowels, and then for whatever reason you develop an anal fissure, and then it doesn't heal, and then you develop that sort of fear avoidance behavior where before you empty your bowels you actually get tense, right? And then there we go, then we have that elevator on eye syndrome, and it was an evacuation difficulties to start with, right? So I want you to start thinking about that. And then what about low anterior resection syndrome? So this is the consensus that came out last year. And then, at the moment, obviously, I'm not sure if you know that bowel cancer is the third most common cancer in the world. And with the advancing treatment, also we have patients that then ended up having consequences. And I can see that exactly in the same way as, for example, the prostatectomy patients, right? So now they're getting better with the robotic surgery, but then they end up having urinary incontinence. So with the bowel patients, more or less, it's exactly the same. But to meet the definition of low anterior resection syndrome, a patient must have an anterior resection, right, where the sphincter and their preservation of rectal resection, and experience at least one of those symptoms that results in at least one of these consequences. So, variable and predictable bowel function. And then remember that sometimes an alter the stool consistency and increase stool frequency. And remember that some of them will also have radiotherapy. So all of that will come from that. Repeated painful stools, difficulty evacuation, they might have an urgency, incontinence, and soiling, and actually they have a mixture of post-defecation soiling and actually passive soiling. And the consequences is obviously they might have to be close to the toilet, obviously they stop all the sort of roles, commitment and responsibility. There's a huge impact on quality of life. They tend to develop very much the same sort of fear avoidance behavior of, urinary incontinence, not leaving the house, going with nappies all the time. So, an interesting group of patients to treat. And then obviously we have the incontinence, and I think as physiotherapists we have always been more inclined to see this type of patients. And then obviously when it comes to incontinence, we have fecal incontinence, as you know, is the involuntary loss of liquid or solid stool. That is a hygienic problem. But then we have flatus incontinence, which is the inability to control wind, passive fecal leakage, whereas, for example, with the fecal incontinence, you might have that it might be a rectal capacity combined with a weakness of the anal sphincter complex. Passive fecal leakage most of the times is actually disruption of the internal anal sphincter, most of the times because of obstetric anal sphincter injury. And then you might have someone with overflow fecal incontinence because they are impacted, all right? And obviously then we have urge fecal incontinence again, someone, for example, who, again, obstetric anal sphincter injury is a good example of someone who might have a defect or low squeeze pressures on the manometry, and they need to run in order to empty the bowels, and if they don't get there, they actually have an accident. So, and then again, some of the symptoms, they might actually overlap. And then remember that the main the main reason to have incontinence is childbirth, and OASIS, obstetric anal sphincter injury, remains to be the first cause of incontinence in the young women population. But then again, surgery, just having, for example, a sphincterectomy because you have a chronic anal fissure, diabetes, having anal sex, incontinence. So there is sort of a correlation between urinary incontinence and fecal incontinence, obesity, and any sort of disturbance of the bowels, like irritable bowel syndrome, inflammatory bowel disease, or chronic diarrhea and constipation. Yeah. But I really, I think sometimes we can get hooked up into all the terminology and the description of the pathology. And actually, when I'm in clinic, I'm very much, sort of see what the patients say, because, and most of these patients, especially when you're in a colorectal unit, they might have an overlap of all the different symptoms. So, a typical symptom is obviously straining, incomplete evacuation, digital assistance. And for example, digital assistant, depending on how they do it, it might give you some information. So for example, patients might actually be splinting or perineal support, or thumb through the vagina. That sometimes might give you an indication that is a rectocele, for example, or perineal descent. Whereas someone with anismus or paradoxical contraction of the puborectalis, they might need to stretch. And then someone again with a rectocele might need to scoop. Yeah, so I'm always like, oh, all right, are you using your fingers? Are you scooping? Are you stretching? Or are you supporting? Yes. And then again, a big one is actually the constipation, like demystifying. So, when patients said, oh, I have constipation, the first question is like, is it constipated? Are you constipated, or is it difficult? Okay. Because constipation, as you all know, is very much, opening your bowels less than 3 times per week. So but the majority of patients will actually get confused about that. How long did you spend on the toilet? Like, so on Wednesday, a lady spends 2 hours. And my first question was like, but can you just walk out of the toilet when you spend 2 hours sitting down? So trips to the toilet, again, someone that fragmented defecation, so someone that has, for example, intussusception, which is the telescoping of the rectal wall. So, they might find that feeling, they might have that feeling that they want to empty the bowels all the time, but they can, and they strain, and then they might actually then use digital, assistance, and then they might then develop a rectal ulcer. What happens with the post-defecation soiling, which is completely different from the passive incontinence, for example. Remember that post-defecation soiling might be related to a rectocele most of the times, or maybe that discoordination, you're not emptying properly, and then you have a weakness of the sphincters, and off you go. Whereas passive incontinence and post-defecation soiling might happen shortly after emptying your bowels, whereas passive soiling might happen throughout the day. And then again, a stool in my pants, those women that actually have some sort of anatomical defect on their sphincters, and then they say, oh, I keep wiping all the time, Paula, I need to use wet wipes, unable to control ween. I think this is one of the most bothersome ones. Pain during defecation, is it one of those sort of organic conditions such as anal fissures, or is it actually more related to the pelvic floor? So I think, sensation of blockage, again, that might be actually a rectocele, but there might also more likely to be a rectal prolapse. And what's the difference between the two of them? Sensation of blockage, for example, if there was a rectal prolapse, patients will say, after I empty my bowels, I have something coming out that I have to reduce. And then you just might actually need to get into clinic and ask them to show it to you. So I always say, just go along with what the patient is saying, because it will guide you much better than actually going through conditions that's my personal experience. Obviously, when we assess, I think it's very important from us that what we do in our clinic or in our unit, very much we tend to ask questions about pelvic floor in general, because very rarely patients will have one disorder. So they might have, bladder, bowel prolapse, a combination of them, but plain, what is the relevant past medical history? They have had a hysterectomy, and a cystocele repair, for example, which is more likely then to give you a rectocele. What medication are they taking? Is there a pain? Do you need to go down the route of assessing pain and psychological assessment? Someone with functional, unspecified functional and erectile pain, you always have to wonder what happened there, for example. And very important when you're seeing bowel dysfunction, that you actually exclude any red flags. So remember, PR bleeding, change in bowel habit, and bowel changes, and outcome measures. You can actually use the ICOQB. That's what we use in the pelvic floor unit. The Bristol stool chart is a good measurement for incontinent patients, and then using a bowel diary that will actually just tell you what the patient is doing. And I used that for both bowel evacuation and incontinence, actually. And you tend to go through abdominal, digital vaginal, digital rectal examination. I think that's the key one, and a pelvic floor muscle assessment. And I really enjoy your presentation this morning, Helena. It was absolutely great. And, once, we have done for that, if during that sort of first initial assessment that we see, if anything is not right, then we tend to sort of discuss it on the MDM, and then we may actually refer to endoenal ultrasound in a rectal physiology or a proctogram. And then I most likely, especially the ones with functional and rectal pain or functional pain in general, might actually refer for psychological assessment and refer to the pain team if I haven't been referred before. And so, what I want you to sort of get is that overall, the goals of physiotherapy are to optimize pelvic floor muscle function. And that goes from either strengthen to actually to normalize or to relax. I don't like the word relax. I'd probably use more optimize or normalize. Improve stool consistency, especially, obviously, patient with incontinence, we need to make sure that they have a harder stool, whereas probably in evacuation difficulties, if I have a type 1, we actually need to improve that sort of to a type 3 or 4. Improve rectal capacity, and that means, for example, in patients with fecal urge incontinence and hypersensitivity, for example, we need to actually increase rectal capacity, right? And keep the rectum empty. And what that means is that we need to ensure that both bowel evacuation and incontinence patients empty the bowels. In the incontinence group is to allow them to sort of plan their day, sort of ensure that they don't have any accidents, whereas in the bowel evacuation is to avoid that sort of really wrong behavior that is associated with not emptying the bowels, right? Not leaving the house, sitting down on the loo for a long time, etc. So I'm just going to sort of go through all of this, and then at the end, if you have any questions, please do ask me. So I think and I'm quite sure that I'm going to forget about things. Okay, so please do forgive me about that. This was a very heavy, presentation with lots of information. But obviously, the first thing to do with you have someone with constipation or bowel evacuation difficulties is, as I say, review the medication and education and myth busting. So, what are you drinking? What are you eating? What are you doing? In terms of bowel retraining, how are you sitting down? Are you using your squatty potty, of course? Rectal balloon techniques, do they have, if they have a combination of, sort of bowel evacuation because of this synergic, puborectalis, do we need to do balloon expulsion training, for example? Abdominal massage, I'm such a big fan of abdominal massage with a tennis ball. I tend to give that probably to almost everyone, either you have bowel evacuation difficulties or not. But hey, transanal irrigation, we are big fans in our unit, and we give it to mostly everyone. And whereas before, when we started using it, we were like down the route of doing a few things before. Now I can see when I see patients that actually you need it straight away. I need to go through everything before I get to that, for example. And low volume irrigation, remember, we might use it in this group. For example, if you have a rectocele and you have postification soiling to clear that, whereas high volume, we might actually use it for someone with, sort of slow transit constipation, for example. For me, it's, I don't know if you have seen, it's a gadget that you can actually use, but in clinical practice, most patients say, Paula, my finger is as useful. And pessaries, like the use of cube pessaries, like for example, on Wednesday, I put a cube pessary in a patient, and that just, for example, if someone who's got a rectocele and perineal descent, it's actually quite good to give support to the area. And then if any of this bowel evacuation is because of abnormal tension of that pelvic floor or increased tone, as Helena was saying today, do we need to actually manage that before we go into anything else? Incontinence, dietary modification, again, what is the patient eating, not eating? Do we need to add any sort of fiber? Do we need to ask them to start taking, psyllium, for example? And we know that psyllium is as effective as loperamide and actually gives them less abdominal bloating. Lifestyle modification, what are they doing? Do they need to lose weight, and do they have all of the information available? For example, the toilet map finder, do they know what what medication, like for example, there's a medication called Orlistat, which is quite famous to give patients incontinence, and is given to obese patients to lose weight. So most of the times we have those patients referred to as bowel training. What I mean by that is, do we need to sort of not only teach you how to empty your bowels, but actually this is when we talk about urge control techniques, and then increasing that sort of resistance. Pelvic floor muscle training, do we need to increase not only your pivorectalis to increase that rectal angle, but also make it very specific about the external anal sphincter. EMG biofeedback, loving the previous presentation. We use it in clinic. I probably, and I don't want to create controversy in here, but I probably use it more from the motivational point of view, in a way that the patients can see what they're doing on each appointment. Electrical stimulation, we don't use it very often. Rectal balloon training, I use it more with hypersensitivity patients. Anal devices, anal plugs, again, super useful. And we have the Coloplast, we have the Renew, and now we have the new Kitchen Town, which is the Navina insert, which is quite comfortable as well. And again, I go back to the transanal irrigation, which we're quite good fun. And then sometimes we will refer patients for PTNS before we refer them onwards. We don't use it in our unit, but it's something that these patients might actually benefit. Pain syndromes, again, big thing about pain education, especially depending of, what you find in your assessment. Again, you might go down the route of, if depending on how much is the pain sort of influencing the bowel evacuation, you may actually go through the whole defecation and the things that we have talked before. But in this specific patients, I tend to sort of go down the route of pain education, diaphragmatic breathing, exercise-induced hypogeusia. So, just get them into an exercise routine, manual therapy. And what I mean by manual therapy, is either, you do field massage, do you do, contract the stretch, what do you do? Do you use a TheraOne, for example? I'm a big fan as well of TheraOne. Do they have to use anal dilators, for example? Ergonomic advice, remember those patients that actually come down, come and they don't want to sit down because they have anorectal pain, sort of, are you sitting down? And with that, actually, I forgot to include graded motor imagery. So for example, how are you going to get those patients that don't want to sit down when they get to clinic to sit down? Therapeutic exercise, big fan of stretches, pelvic floor stretches, and use of pelvic floor contractions. I'm actually ask patients to contract slowly. I don't ask them to hold on, but I ask them to sort of normalize by contracting and relaxing. Relaxation strategies, you have the Shelley Proscope, toilet yoga, you have mindfulness, you have the Mitchell method of physiological relaxation. Yoga is a big thing, and defecation dynamics, as I said, all the things that we have to talk about, from the bowel evacuation and difficulties. And then Lars, I think it probably is a combination of all of them, but probably we will start with dietary modification, and again, defecation dynamics. How do you sit down? Do we need to speak with the consultants about medication, like loperamide? And when it comes to loperamide, we tend to sort of prescribe liquid loperamide rather than, capsules or tablets, for example. Do we need to go around the sort of, what do they do during the day? How are we going to sort of organize their day? Pelvic floor muscle training, there's some evidence there. Biofeedback, again, anal devices, that's a big thing for them actually, and transanal irrigation. Again, I think those two, anal plugs and transanal irrigation, are a big thing for this group of patients. So I think my take-home messages, I hope this wasn't too overwhelming. It's quite a lot of information, so I apologize for that. But I hope that it's giving you sort of a nice sort of overview of bowel dysfunction. And I think my advice would be, when you treat these patients, that you listen and you go back to the symptoms rather than the conditions, that you spend time on the assessment, because most of the times that is, what it will guide your treatment. Agree on clear functional goals with the patient. I think nowadays I'm more about, how is this condition affecting your life and how are you going to do about it? So the whole motivational interviewing that we were talking before, I'm for first line management. And what I mean by that is my mainstay is educating the patients, correcting the wrong behaviors, pelvic floor muscle training, transanal irrigation and fan anal plugs, and then get fancy, maybe use the EMG biofeedback, maybe use the rectal balloon training, and then in any case, liaise with the medical team about medication. So thank you for listening, and I welcome any questions.
Thank you, Paula, for a fantastic overview of the role of physiotherapy in the management of bowel disorders. It's really a challenging but incredibly interesting and diverse area to work in, as you can see from that a huge amount of things that you covered in such a short time. So well done. I think we really do owe it to our patients. Even though bowel dysfunction may not be our cup of tea, I think we really do owe it to our patients to take a good bowel history, no matter what problem they're presenting with. I think sometimes it gets a little bit overlooked. Obviously, as Paul has pointed out, there's a lot of things to get your head around, but taking a really good history is a fabulous way to start. So thank you, Paula. Now we've got lots of questions coming in. I'll try and get through them. First one from Alison Bryant. She says, thank you for an incredible overview. Do you have any tips for those patients who have persistent loose stools after using your stool bulkers, loperamide, Questrin, that there's a percentage of patients who continue to have loose stools?
It's actually, do you mean like chronic diarrhea?
I think that's what Alison's indicating, yes.
I think most of the times, that will be one of the patients that I might actually refer to the medical team to maybe they actually give them codeine phosphate, for example, to harden the stool. And then, if that the psyllium or the loperamide is not actually good enough, then that's what I will do. I don't know if that answers the questions, Alison.
And I think, you've talked about irrigation and sometimes do you see a role for that in these patients with like chronic diarrhea, even when they've exhausted all the medical and medication options?
I think provided that there's no sort of inflammatory disease or anything going on, absolutely. I think in our unit, we are quite a big fan of transanal irrigation, but actually with the patients with the chronic diarrhea, I'll want to make sure that there is nothing else going on and that the medical team are happy for us to use it. But yes, quite useful. The other thing as well is you have to remember as well that chronic diarrhea or any of the sort of anal incontinence patients, they might actually develop things like, precious ani or that sort of eating and burning around the skin, for example, when they have an associated sphincter defect. So, that chronic diarrhea can actually lead to that as well. So, it just depends what is the presenting problem. But, someone with chronic diarrhea, you want to make sure that nothing else is going on and you're actually allowed to use irrigation.
Mm-hmm. Another question from Berbel Jungiger. Can you give some information on what physios can do for proctalgia fugax? Is there evidence for something?
Hardly anything, because the difference between, for example, functional and erectile pain when the elevator ani is being involved versus proctalgia fugax. Remember that proctalgia fugax is that sort of very intermittent, random pain of the anus. And so it doesn't have like a predictable time. It doesn't come after defecation. It just comes. So I think what we tend to say in our unit is actually contracting the pelvic floor, like really squeezing up, heat therapy, getting into the shower and having hot water, sitz baths as well. And then, some patients actually take ibuprofen treatment. But from physio point of view, if they have it, that's what I would go through, pelvic floor contraction, because after a pelvic floor contraction comes natural relaxation. So in some patients that helps, but it's more around heat therapy, having a hot water bottle there, and some water in the back passage. I don't know if that answers your question, Barbara. What do you think, Angela? What do you do?
Yeah, because there is a link between episodes and increased stress and increased pelvic floor tension. And so definitely you'll talk to patients, and after you've done your down training with them, the episodes just become far less. And, stress management, of course, as well, is really important for those patients, and reassurance that it's not not life-threatening, even though it feels it.
Yes, absolutely.
Okay, sorry, I'm just scrolling through these. A question from Alice Carvalhay. Great presentation. How do you assess rectal capacity?
Oh, that's a very good question. Obviously, rectal capacity, you might actually need to use, rectal balloon, not training, but yes, rectal balloon. Most of the times for rectal capacity, some of our patients will come within a rectal investigation, so we will know then. So that's quite handy, when you if you don't have that, just by using, the rectal balloon and then sort of instilling air in the rectum, it can give you sort of a rough idea of how much you have. I don't know if that answers the question, or if anyone else has any other suggestions. That's what we will do.
I think you answered some of these questions. Another question from Berbel Junginger. What about teaching patients to, simulated defecation with real-time ultrasound as biofeedback?
That is actually super fancy. Real-time ultrasound and defecation. Well, I don't think I have done it before, actually, because if I do defecation training, I'll probably actually get, I do then get the commode. So this is actually a whole sort of a range of get the commode, get the mirror underneath, get the patient on the squatty potty or a stool, then sometimes obviously get the balloon. Sometimes if I get catheter or the balloon, I put it with water, for example. It's actually far more real. And then that's how I actually train simulated defecation. That's far more effective. I found that if you try to do that with patients inside lying, it's just not physiological. So if I found that on the examination and I don't have time, I'd rather ask them to come back for a further assessment with a further appointment, so we can actually get down the whole get him into the right position, and then actually then coordinate the abdominal muscles and the breathing, and then just repeat that a few times so they actually get that in their head before they go home, rather than the real-time ultrasound. I have never done it, so I would love to hear whoever has asked me about that, because I have never done it. So please come and talk to me at the end.
It is possible. It is possible to do it on a commode with the transperineal ultrasound probe on the perineum. So sitting exactly like they would on the toilet. So it's a bit like doing rectal balloon training on a commode, but with an ultrasound probe instead. And I guess you can see exactly what the anorectal angle is doing and how much descent's happening, and you can modify things in a less invasive way, I guess. But it's it's like everything. It's a bit tricky.
But then, do you need an assistance as were you doing that as well? Gosh.
You need a third arm sometimes. Any clinical pearls? This is from Tanvi Maharaja. Any clinical pearls for fecal incontinence post-chemo radiation for treatment of anal incontinence?
I think you getting...
This might be our last question too, Paula.
Yeah, I think literally get onto the sort of the stool consistency, literally. And, remember that most of the times, yes, get the stool consistency, get the good defecation dynamics, and actually are probably depending on, where they have radiotherapy as well, or, when they have the surgery, I probably use irrigation and the anal plaques.
Thanks very much, Paula. I'll hand back over now to Heather. I'm sure there's a lot more questions that you'll be able to answer later. Thanks, Heather.
Thank you.
Thank you both so much. Yeah, Paula, you can get on and answer the few questions that were left. That was a fantastic presentation. So we're going to be breaking now. So join us in the live lounge for the next 30 minutes so we can meet and chat virtually. So you can follow the link that's in the live lounge, and it's just below, and just follow your steps. Create an avatar, and once you're in the live lounge, you can move around with the cursor and get close to people and chat. So we will resume back for the second half of our session in 30 minutes, and so we'll see you in the live lounge. Thank you, everyone.
Hello, everyone. Welcome back. So welcome to the ICS 2021 Melbourne Online and the second session of this wonderful 20th Physiotherapy Forum. So we're pleased to welcome all delegates watching, either live or on demand. My name is Hayley Irving and I'm proud to chair this event on behalf of the local physiotherapy subcommittee. We were so looking forward to hosting you all here in Melbourne and had grand plans of introducing you to our beautiful city with trendy lane-way cafes and rooftop bars, but instead we find ourselves here online again. So if you're like Nellie and have your wine, or like me, we started at 6:30 this morning and now it's 8:30, so we've got a cup of tea. So I hope you have something that's going to keep you warm and yeah, enjoy the rest of the session. It's a fabulous physiotherapy feast ahead, but I did also want to bring attention, as Nellie did, to Rebecca Day presentation on OAB. It's wonderful, and there's a link below of the page, so definitely take the time to catch up on that. Continue to use the comments functionality to say hello. It's been wonderful to see the beautiful formal and informal conversations happening in the chat function. So keep going. Even if you're watching on demand, you can still participate in that. So we'll be here to field your questions, and let me now hand over to Claire and Trish.
Thank you very much, Hayley. So I'd like to introduce Patricia Newman. So Trish is a specialist women's and men's health physiotherapist and fellow for the Australian College of Physiotherapists, awarded in 2010. She has a PhD from University of South Australia and has just retired from clinical practice after working exclusively in the area of pelvic floor dysfunction for the last 30 plus years. Trish has also co-designed and lectures at the University of South Australia on the short course Conservative Management of Pelvic Organ Prolapse, which awards a professional certificate in prolapse and pessary management. She is a member of the International Urogynecology Consultation Committee on pessary management, the author of 3 book chapters and more than 20 peer-reviewed papers on pelvic floor dysfunction in men and women. She is involved in research and is a reviewer for a number of journals. I will now hand you over to Trish.
Thank you, Claire, and welcome everybody. Welcome to this topic and to Adelaide, Australia, where I'm speaking from. I'd like to thank the organising committee very much for allowing us this opportunity to talk about pessaries for prolapse in this international forum, and I do look forward to the discussion with all of you at the end of this session. I am happy to be sponsored by the ICS for this conference, and my only affiliation is with the University of South Australia, where Claire has already said I'm a lecturer on the professional certificate in the conservative management of pelvic organ prolapse, which also trains in pessaries. Over the next 20 minutes or so, I will talk to you briefly with an overview about pessaries, look at the evidence and clinical practice guidelines, but spend most time talking about training standards in pessary management. I will contend that physiotherapists do have a role in pessary management as part of the whole suite of conservative management options for prolapse, and that the wider availability of pessaries would benefit women in both high and low income countries. But to be within physiotherapy scope of practice, I will maintain that we need to be competent and we need to agree on pessary training standards so that we can deliver safe and effective care. And I really look forward to the discussion at the end of this session with you all. Prolapse is a huge global health problem affecting more than 40% of women in the low-income countries. There's even greater prevalence of prolapse, affecting not only women's quality of life, but their very life and existence. Multiparity, poor nutrition, and carrying heavy loads are contributing factors. But what is a pessary? Well, since ancient times, women have borne children and have developed prolapse. And women have been creative through the ages in finding ways to self-manage their prolapse. And here you can see a half a pomegranate which they soaked in wine to use as a pessary. But times have changed and modern pessaries are made of vinyl or silicone. The silicone rings have the advantage that they can be folded to make insertion and removal easier, and they come in a multitude of shapes and sizes. I've only shown a few samples here. What role do pessaries play in prolapse management? Well, they're considered part of first-line management for prolapse by the ICI and also in the NICE guidelines. Traditionally, they've been gynecology scope of practice, and in gynecology hands, they're considered low cost and low risk. Now, this is potentially of an advantage not only to women in the high-income countries, but also to low-income countries. And in fact, there have been several papers published on the use of support pessaries in Uganda and rural Nepal. How do women feel about pessaries? This recent systematic review looked at women and healthcare providers' knowledge, attitudes, and practice related to pessaries for prolapse. And they found that women actually have very limited knowledge about pessaries. And if they do know something about them, they're likely to have a negative view. Their perception's been influenced by the training that their provider has had and their attitude to pessaries. A recent study from Brazil of gynecologists showed that more than half of the gynecologists don't provide pessary care, and the reason, predominant reason for that was because they didn't have the training or experience. Women also have limited and biased information from lay media. There is very poor quality information available to them. And there are personal barriers. Women fear the side effects of pain, discharge, bleeding, and for some it's the dislike of touching their genitals regularly that's required. But a pessary can be a life-changing experience. It can enable women to lead active, engaged, and social lives. But they do need support to develop comfort and confidence with actually manipulating and caring for their pessary. Now, for physiotherapists, the idea of splinting a joint, strengthening muscles, and helping women to engage in the things they want to do has been around for a long time. And this can be applied in pelvic organ prolapse, where we can use a pessary to support the boat and then strengthen the muscles and then get back to life. But what's the evidence for pessaries? In this recent Cochrane study on pessaries for managing prolapse in women, they found 4 RCTs covering 478 women. And the authors' conclusions were that we are uncertain if pessaries improve pelvic organ prolapse symptoms for women compared with no treatment or pelvic floor muscle training. But pessaries, in addition to pelvic floor muscle training, probably improve women's pelvic organ prolapse symptoms and their prolapse-specific quality of life. However, there may be an increased risk of adverse events with pessaries compared to pelvic floor muscle training. Our moderator, Claire Brown, has pioneered physio self-management of pessaries in a physio-led clinic. And now in the UK, they have just published this protocol for a randomized controlled trial. This is a multi-center RCT to test the clinical and the cost effectiveness of self-management of vaginal pessaries compared to standard clinic-based care to improve women's quality of life. Now, there's nothing like a cost effectiveness study to change public health policy. So we really look forward to the results of this great study. But can all women be fitted with a pessary? We like to think that we can do that, but in fact, no. Success will depend on many things, not least the training and the expertise of the health professional fitting the pessary. In this first study, 142 women in Nepal, 94% of them were successfully fitted, but at 12 months, only about half of them were still using their pessary. In this other UK study of 246 women, about 3/4 were successfully fitted and retained the pessary for 4 weeks. And of these, about 86% of them continued successfully for more than 5 years. Now, I'm not going to talk about all the different types of pessary. There are as many as there are letters in the alphabet, nor am I going to talk about all the things that influence the success or failure of pessary fitting. You can look into the excellent new UK clinical guidelines for more information on this. I'm going to turn our attention to the role of physiotherapists in pessary management. We have these 4 surveys. The first of them, a UK survey done back in 2012, which showed that there were 7 of 527 respondents. So 1.4% of physios in the UK were using pessaries. In 2020, 22 physios, or 5% of respondents, were physiotherapists. Another study of UK healthcare providers found 10 physios, or 8% of physios, were providing pessary care. And most recently, this French survey of healthcare providers, a big response of over 1,000 people, found that 208 physios, or 20% of those, were actually physiotherapists. So what about health practitioner training? Well, this study by Lucy Dwyer and co-workers in 2021, just recently this year, a service evaluation to determine where and who delivers pessary care in the UK, found that 15.2% of healthcare professionals had no training at all. They concluded that a standardised approach to pessary practitioner training is needed to ensure that women receive safe and evidence-based pessary care. This review of pessary for prolapse practitioner training, also by a UK group, found that despite the extent to which pessaries are used in the UK, there are no clear guidelines regarding the training required for pessary practitioners. And they concluded that professionals must learn from the current situation with mesh to protect themselves as practitioners, to protect the availability of pessaries as a treatment option, and most importantly, to protect their patients. So what's all the fuss about training? Well, there are risks associated with using pessaries. In gynecology hands, they have been deemed to be low risk and cost effective. But are pessaries safe in physio hands? We have no data on this. And who is keeping records and reporting adverse events? To my knowledge, not many. I'd be happy to hear from people who are doing this. This group developed a severity classification of complications related to pessary use. And they developed this classification of complications based on the Clavian-Dindos system, which is used for complications in surgery. So this group considered that the complications from pessaries were severe enough potentially to warrant a classification system. Now, I don't expect you to be able to read all of this, but I'll just point out that it goes from grade 1, which includes complications such as vaginal discharge, ulceration, pain, bleeding, constipation, and material allergy, down to grade 5, which is death of a patient from incarceration, enterovesical fistula, obstructive uropathy, and urosepsis. So we need to be warned, I think, that there are potentially serious complications associated with pessary use, and we need to be monitoring complications and adverse events and reporting them. I think you'll all agree that women have a right to best practice standards for optimal outcomes and safety, no matter where they are in the world. But how do we deliver this? Sure, clinical practice guidelines are a start. However, these guidelines, which were produced in 2012 in South Australia, were not endorsed by the Australian urogynecologists simply because there was nothing about practitioner training in them. Now, the NICE guidelines also have nothing to say about practitioner training, but the latest UK clinical practice guideline does have a whole appendix devoted to practitioner training. So I will refer you to that for further reading. Now, if I as a physiotherapist want to move into a new area of practice, this is what the Australian Registration Board, the Physiotherapy Code of Conduct, has to say. Good practice involves when moving into a new area of practice, such as pessary management, which was formerly gynecology scope of practice, ensure that a practitioner has sufficient training and or qualifications to achieve competence in that area. But what is competence? This paper, An Argument for Competence-Based Training in Pelvic Floor Physiotherapy Practice, describes the steps in training and practice to achieve competence, starting with a knowledge base, technical skill development, clinical reasoning, mentoring, and the achievement of competence. And throughout that process, professional communication skills are honed, and there is assessment of each step. Now, Frawley et al. Argued that this was necessary for the achievement of what I might call basic pelvic floor physiotherapy. So why would that not apply even more so to the area of pessary management, which is a more advanced part of practice? Now, in Australia, in the public hospital sector in Victoria, which I've marked with a little arrow here for you to see. So the arrow points to where the Melbourne part of this conference is happening. So in Victoria, they have developed pessary competencies as part of advanced physiotherapy practice. And these are for ring pessaries, to be able to fit and refit ring pessaries. Now, these competencies apply in a small part of Australia, but they are not adopted nationally across the country, nor are they adopted in the private sector. In fact, there are no pessary training standards to guide private practitioners, which I estimate is the most physiotherapists in all of Australia providing pessary care are in the private sector, in private practice. So to fill this need for guidance, this study, the development of a multinational and multidisciplinary competency framework for physio training in pessary management, this study was undertaken to provide some guidance. It was an eDelphi study, which included experts from 6 countries and from 3 disciplines: physiotherapy, expert nursing, and urogynecology. So the first item was to understand what these experts felt about prerequisite knowledge and training. And the panel of 29 agreed that physiotherapists should be competent in the management of pelvic floor disorders before undertaking pessary training. And they deemed this was complete agreement that this was an area of advanced practice, so not for novice physiotherapists to undertake. And there was also complete agreement that competence should be formally assessed. So this framework, this competency framework, describes 10 physiotherapy roles, each with supporting pessary-specific competency standards. Now, these 10 roles are based on the Canadian CanMeds model of education that has been used for physician training in Canada. And it's also the model that was adopted by the Australian Physiotherapy Association when they designed their career pathway. So these roles will be familiar to some of you. These roles cover physiotherapy knowledge, clinical skills, clinical reasoning and decision-making, communication and interpersonal skills, collaboration, scholarship research and evidence-based practice, leadership and service management, education and clinical mentoring, profession-related matters, and health advocate. So I think this allows us to see that there's a lot more to managing pessaries than simply being able to fit a ring pessary and take it out again. We hope that this framework of competency standards provides a benchmark in training standards for physiotherapists, not only in the Australian healthcare setting, which it was designed for, but also that it can be of use to physiotherapists internationally because of the wide representation of physios on our panel. We propose that it can be used as a checklist for clinicians to self-assess their competence, to identify any gaps in their competence, and to seek training where needed. We propose that it also can be used as a guide for educators designing pessary training courses. So that's it from me. Thank you for listening. And now let's talk. I'd be really interested to hear your thoughts. I'm interested to know what you think about physiotherapy training. Should we be trained at all? Is this necessary? If so, what should that training look like? What standards should apply? Should pessary management be advanced physiotherapy practice? And how can we make training widely accessible? For anyone who wants to communicate with me further on this topic, I'd be really happy to hear from you, and here's my email address. Thank you. Over to you, Claire.
Thank you so much, Trish, for that, for your talk today. Your work has been so important for the profession moving into, for physios to move into the world of pessaries. And I know how long these things can take. So thank you for your passion and hard work. So as we're getting a few questions coming in, there's a few comments from Marika Slika Tenhove to say that the physios in Netherlands are not allowed to put the pessaries in. And that's the same for Germany. And from Cheryl Pavlov-Shaprova from the States, in upstate, in New York State, urologists primarily perform the pessary fitting. So please keep typing in your comments and your questions, and we'll talk a bit more about that. But Trish, in the meanwhile, while we wait for a few more questions to come through, I wondered if you had any thoughts about why it's been important just to train physios, and your work is primarily just focused on that profession rather than looking at the wider multidisciplinary team.
Claire, well, I think we need to get our own house in order first before we go trying to preach to others about what they could do better. And I think we've got a long way to go to get our house in order. So I think that there are going to be opportunities to share what we've done with other professions. But I think we need to first come up with something that allows us to do this well, because I'm quite concerned about those messages about the learning our lessons from mesh. I think it's been really tough for the urogynecologists and to deal with the fallout from not having done their homework properly with mesh. You know, they've been told now to look at their training, to document adverse events, to really make sure that they've dotted their I's and crossed their T's, and that they're doing this in a much more professional way. And I think that we really should be warned by this, that if we don't get this right, if we do find that physios are doing this badly and we're causing causing harm to women, that we may lose the privilege of being able to do this. And as we've just heard from Marika and from Germany, they're not allowed to fit pessaries in those countries. And there are still urogynecologists in Australia who are hotly opposed to us providing pessary care. And this is all about training. They don't think, some of them don't think we're well enough trained. Now, some do, and in the hospital setting, there are competencies in place for physios to complete. And in those hospitals, if you completed the competencies, you are able to be part of the multi-D team and look after pessaries. But we need to make sure that we have these sorts of standards across the board and not just in the hospitals.
Absolutely, thank you. We've had an interesting comment from Claire Jones in the UK. Just a comment to say that even in the GP surgeries, especially with COVID, some women are struggling to be seen. And there are massive lists in the pessary clinics in hospital with COVID waits. Is there anything more that physios can be involved with? So more than just a ring pessary, do we have a bigger role to play?
Well, I think the competencies, the Victorian competencies were just for ring pessaries, but I think that physios can fit other pessaries, and we certainly teach that on our course at UniSA. We teach physios how to use space-occupying pessaries as well. And that requires more knowledge, more skill, but I think you need to be trained. I don't know that there's anything that we can do about this unless we establish proper training programs and upskill physios to take their part in this. And I think this also applies to GPs. We're just completing a survey for the International Urogynae consultation, and GPs have no training at all. And in primary care, there is such a role for physios to be working together with GPs. And if we can get them trained so that this can all happen in a primary care setting, it would make pessaries an option for so many more women and allow them to live more active lives.
Lovely. We've had a really good question from Cheryl Pavlov-Sheprova from the States, saying, could pessary training be something that you take virtually, or do you feel it needs to be taken place in person?
This is such a difficult question. I think there is lots that you can do virtually. Certainly our course at UniSA is done mostly online, but we have 2 practical weekends for that face-to-face training. But of course, COVID has made that really difficult and has caused us to be much more creative with how we deliver that. But I think there is a component of this that has to be practical. I think that's something that for competence you can't avoid. So yes, a lot of it can be done. The knowledge can be gained online. You can look at how to do it, but you actually do need that practical training and supervision of how to do it in real life, because it can be very tricky.
Lovely, thank you. And from Angela James from Australia, she mentions, given the risks in addition to what we know about achieving competence, she can't see why we wouldn't adopt more rigorous standards for pessary management in Australia. And what do you think that the barriers are to taking the next steps?
Oh, Angela, I think, yes, I agree. We need more rigorous training. We need to get our associations on board. I think the Australian Physiotherapy Association, I hope, will step up and join a discussion on standards of training. At the moment, that is something that has yet to be developed. So I think it's talking to our professional bodies, getting them to embrace the need for professional standards and to work on adopting them and recommending them for physios. We can't mandate it, but we can make standards. Set minimal standards for people if they want to practice in this area.
Lovely, thank you. And then another lovely question from Barbel Junger from Germany. I always use different type of tampons, so cube or incontinence tampons, because pessaries are not allowed and tampons are.
Do you think this is a way patients can get interested and can get the same success?
So using a tampon rather than an actual pessary. Yes, well, I think women who are used to using tampons don't have much trouble transitioning to the idea of a pessary because they're used to doing it. But and yes, I mean, for some women, just using a tampon with very mild prolapse will be helpful. So I'm not sure that I've answered your question, Barbara. Claire, does that answer the question for her?
I think so. We're getting some lovely questions. I'm scrolling through. So some very good chat coming through. Thank you, everyone. So from Laurie Fauna in Australia, do doctors fitting pessaries have competency training?
Laurie, this is something that physios like to point out, that doctor training, that physios have in some respects better training than some of the doctors. And I think it's something we're investigating at the moment in the IUC consultation. And the standards vary considerably. And yes, some doctors do have competency-based training. And I think it's tempting to say that physios can do this better than doctors, and I hear physios saying this, but there are many areas. Maybe we can do some things well, like teaching women self-management. I think we'll take the time, we'll do this thoroughly, we'll empower women to feel confident with their pessary, but there are areas where we have really no skills. We need that support of our medical colleagues to exclude pathology, for example, or where there's possible infection. We don't do swabs, we don't interpret those findings. So I think this, and I can't emphasize this enough, it needs to be a collaborative approach to managing pessaries. This is not something that physios do on their own. This needs to be co-management with medical practitioners, and that we need to look to them for the areas that we don't have competence in. So yeah, it's a very mixed bag at the moment, with very varied levels of training throughout the professions and throughout the world, as we're discovering.
Lovely, thank you, Trish. A few more comments coming through. About so Denise Dina in the States say that the legalization is different in each state. Practice acts and legalization in California, we're not allowed to fit pessaries, which is very interesting. And then a message from Patricia J. Jenkins from the States again. In the USA, it's important to find the practitioners that prescribe pessaries and refer for fittings. As physios, we can provide so much more and guidance. And I think you probably agree with that, Trish, that we sit in quite a unique role to provide that.
Yes, I think we do. And I think there's huge scope for us to develop the skills that we need and to do it really well, and then to engage with our medical colleagues to show that we can be a really valuable part of that team. And I think with the changes in women's perception of surgery, I think this is another aspect of this at the moment, in this moment in history where mesh has been banned in so many countries, where where women have heard about mesh, are afraid of having surgery. They're looking for alternatives. And I think this is an opportunity for us to, if we have the skills, to provide women with an alternative, viable alternative using pessaries, and to work with their GP or their gynecologist to provide them with that option. But we need to be trained in order to do that. And this at the moment is a really thorny topic here in Australia, about what standard is required to enable you to fit a pessary. Our association says that it is within physio scope of practice, but there are no training standards to support that. So I think we have a long way to go to sort this all out.
Lovely. Thank you very much, Trish. There are all our questions for today.
Excellent. Thank you, Claire. Thank you, everyone. And do keep this dialogue going with me, please.
Wonderful. Thank you so much, Claire and Trish. The work is amazing, and I think that robust framework that you're giving us is going to give us the confidence, and also our medical counterparts the confidence in us. So thank you. Excitingly, next up we have Beth Shelley, who's going to present to us an overview of the latest pelvic floor muscle assessment terminology update.
I'd like to take this opportunity to introduce Dr. Beth Shelley. She's a doctor of physical therapy and board certified in women's health and pelvic EMG biofeedback. Dr. Shelley's been working in the field for over 30 years and has authored many chapters and professional articles. She's been active in ICS and on the physiotherapy and standardizing steering committees. Beth is co-chair for the most recently published ICS standard terms for pelvic floor muscle assessment and is the author of several other standard term documents. Dr. Shelley lectures to medical professionals all over the world and owns a private practice in the United States where she treats outpatients with all forms of pelvic floor dysfunction. Please welcome Dr. Shelley.
Thank you very much. Thank you so much for inviting me to present this very short overview of a very important document. I will point out that earlier today, workshop 4 was devoted to this document completely. It is open and available to everybody, and I would encourage you to consider taking a look at that workshop for more in-depth. I have no disclosures. I'd like to acknowledge my co-chairs, Helena Frawley and Melanie Morin, and the entire Working Group 16, a group of physical therapists, physician, and nurse all over the world that worked for a long time to create this document. That is now published in Neurourology and Urodynamics. That was in April, and it is available open access to everyone, whether you're an ICS member or not. Please go to the standardization page of the ICS website. Maybe we can even put a link to that in the chat if somebody is real quick on the ball, and you can access the entire document. We included terms applicable to adult, male, and female, including elderly and those with neurological conditions. It is written for both clinicians and researchers, and it covers the structure and function of the neuromyofascial pelvic floor. As all standard documents, it includes symptoms, signs, investigations, diagnosis, and it is fully referenced. Symptoms, of course, are those things that the patient says, and we have included in this document things that the patient would say that would point you to evaluating the pelvic floor muscle. Very important for our non-physio professionals. Signs are the clinical tests, the guts of what we do in our clinic, completed without devices, including visual observation, palpation, and simple tests like reflex or cotton swab. In the workshop 4 handouts, I have included a pro forma, which lists all of the signs and the ratings for easier accumulation into your clinical practice, and especially for documentation. So I really would suggest that you take a look at that handout because this will help you a lot to incorporate quickly. Investigations is clearly the largest part of this document, and it goes into great detail on the ratings and interpretation of dynamometry, myotonometry, all forms of manometry, EMG, ultrasound, and other imaging, and algometry. We also have 5 categories of diagnosis. And remember, this is specific to pelvic floor muscle diagnosis. The disorders of increased tone, notably pelvic floor tension myalgia, the disorders of pelvic floor pain, pelvic floor myalgia, disorder of decreased pelvic floor muscle tone, which is where we would find weakness and decreased endurance, disorders of pelvic floor muscle coordination, including dyssynergia, and the nerve diagnosis of pudendal neuralgia. It is very important to understand a few overall principles when looking at this document. And the first is to avoid the terms normal or abnormal, because in most cases, we don't know what normal is. So we are encouraging people, when possible, to report the absolute value. For instance, the term EMG time to peak activation is time in milliseconds or seconds. Be objective. And transabdominal ultrasound bladder base displacement is the distance, again, being as objective as possible. Also, describing findings in some detail is useful, and this occurs with pelvic floor muscle tenderness, including the location, possibly on the clock, if there is a pain referral, and using the visual analog scale. But in some cases, we have no scale, and all we have is relative terms, as you see listed here. And although these are easy to use, we have to understand the subjectivity of these terms and be very careful in research. But some of the examples are EMG elevated resting activity and EMG slow derecruitment. Each of the tables on the left has the term and the definition. And then in the sign section, there is the rating and the definition of the rating. The right side of the tables of investigations have outputs and interpretation of findings in great detail. This document took 4 years to create. It has 185 terms and it is 44 pages long, a lot to digest. Of note is clarification of the definition of tone. And here you can see the terms that would be used if the patient you're seeing has a neurological disorder. So the term hypertonicity is only to be used in a patient with a neurological disorder. In most of our patients in the clinic, we do not have a neurological disorder, and therefore the term properly to be used is increased tone. Of course, tone has two components, the contractile or active component and the non-contractile or passive component. And we understand that EMG is the only investigation that can clearly discern the active component of tone and the term overactivity in the pelvic floor muscle or overactive pelvic floor. We are recognizing this currently as a finding of EMG, not a diagnosis. It's only one part of what might be a complete diagnosis. And here you can see the findings specifically of inconsistent resting baseline, elevated resting activity, and slow derecruitment. But again, this is really only to be used in describing an EMG finding and only in a term of a finding and not a diagnosis. Until we have more clinical utility research, we advise assessors to exercise great caution in interpreting some of these findings, especially in signs and even some of the investigations, because they yield highly subjective and variable findings. We have a lot of work to be done in this area, and we hope that this research will be forthcoming that will clarify much more clearly. All standard terms documents are living documents, and discussion and refinement is encouraged and necessary. I encourage you now to put comments in the chat that we can address now. I will certainly be going on to the live lounge after this particular section for more discussion, and we encourage email to the office or any of the co-chairs to continue the discussion. Thank you, and I look forward to your questions.
Thank you, Beth. I'm looking on the chat here to see if we're having any questions. And as right now, no, people have asked for the documents, and obviously, as we've noted both in the chat, that all ICS standardized documents are freely available, and the link is listed in the chat.
Mm-hmm. This is a very large document, and it does take quite a bit to absorb. We are hoping that educators and instructors of the coursework for physical therapists and other professionals are going to take this document and really work it into their educational offerings. I do expect that there will also be additional offerings so that those who have already gone through their basic instruction will have more ability to integrate these things into their practice.
Question for you: if a person has pudendal neuralgia, is this considered a neurological diagnosis? This comes from Cindy in the United States.
We decided in this document to include the nerve to the pelvic floor. So the muscle, the fascia, and the nerve. And that is why we included the pudendal nerve and its condition, pudendal neuralgia. That was a decision by the working group.
Thank you. There was another point of just saying it's going to take a long time for people to stop using the language we've been using for so long. So
this is true. And for anybody who knows me, you will get a gentle reminder. If you are going back into those habits, obviously it does take time to adopt. But the really important thing, Heather and others, is that this document really does break apart all of the individual parts of muscle function. And as we continue to adopt these things, we're going to be able to better document and research and ultimately treat all the different pieces of pelvic floor muscle dysfunction. I suspect this is why some of the research we have now does not show a benefit for some of the treatments that we offer, because we're just not measuring the right thing, or we're not measuring it in the right way. And this was the first step to try to be more clear, improving the research and ultimately improving our treatments. And again, we have a long way to go.
okay, well, a couple follow-up questions here. Saying if someone has increased tone with pudendal neuralgia, is it hypertonicity or increased tone?
The term hypertonicity really implies that there is some kind of a overarching neurological condition, such as multiple sclerosis, Guillain-Barré, those kinds of conditions. So I don't think a peripheral neuropathy is what would be included in a hypertonicity finding.
Thank you. Could you recommend some pelvic floor PTs? How would you recommend that pelvic floor PTs can share this with providers to help adopt these terms? Any specific ideas you have? And that came from Cheryl in the United States.
Yes, so it would be a little bit different if we're talking about helping our physical therapy colleagues to adapt versus other physicians. One of the things that was interesting in our workshop number 4 earlier today, we had a urologist who gave a talk about what would be the important parts for a physician to understand about pelvic muscle assessment, because clearly what they do is a lot different from what we do. So I think there is a smaller amount that would be helpful for the physicians to adapt. And I think we just have to gently encourage people and provide a structure and use the terms ourselves. And that will help other people learn. But of course, this is a very big ocean liner, and it is going to turn very slowly.
Very good. It was suggested that making a summary and slowly integrating into clinical notes would be really helpful too. Lots of thanks, and for your exhaustive work on all this, as you said, that extensive document. We thank you for that.
There is one more thing, Heather, I'll mention, is that undergoing at the moment is the creation of what we call a core document. And this happens with some of the other standard documents as well, where it's relatively short. So they're looking for about 4 pages, 4 published pages, to highlight the major components. And that will be a lot of the signs. So for clinical practice integration. So that will be forthcoming, and you should watch for that, because it will be easier to digest and share.
Thank you very much. I was going to say, without seeing any more questions, it was noted in the chat that somebody was having problems getting the link. We will add in a new link to make sure you have access to that, or you can go to the ICS homepages and it'll be there as well that we can put it in. Okay.
Great.
So thank you so much for your work.
Thanks again, Beth. Now I'll hand over to Jane, and who will be introducing Helena and Melanie. Thanks, Jane.
Oh, good morning, good afternoon, good evening, everyone. I think it helps if I unmute myself before I start talking. It is an early morning here in Australia, but welcome from wherever you are in the world. It is my pleasure to be moderating the next part of the forum on this talk of how do I manage endometriosis and provoked vestibulodynia. We're going to be looking at similarities and differences, and we've got two wonderful presenters organised for you today. So I don't really have any relevant disclosures to make, and I'm self-funded, but it is my real pleasure to introduce the objectives of this next talk. So Helena and Melanie are going to compare and contrast basically the differences between endometriosis and provoked vestibulodynia in terms of classifications, definitions, and prevalence of the two conditions, the differences in etiology, pathophysiology, and pain presentations, looking at patient assessment, the different treatments and supporting evidence, and then finally give you some take-home messages. So our first speaker is Helena Frawley, who needs no introduction. Helena is an associate professor in the School of Health Sciences at the University of Melbourne and the Director of Allied Health Research at the Royal Women's Hospital and the Mercy Hospital for Women, Melbourne. She's currently involved in research investigating pelvic pain and pelvic floor dysfunction in women with endometriosis. And I know that she's been really important in putting together this conference. So thanks, Helena. We will hear from her shortly. These are her affiliations. And our second speaker is Melanie Moran. And Melanie is a full professor in the School of Rehabilitation in the Faculty of Medicine and Health Sciences at the University of Sherbrooke in Quebec, Canada. And she's a researcher at the Research Centre of the CHUS. She's the founding director of the Urogynecology Research Lab. She has expertise in chronic pelvic pain and vulvodynia, and she's conducted several clinical trials investigating the efficacy of conservative treatments. These are Melanie's disclosures. And it's now my pleasure to hand over to these two wonderful speakers. Helena is going to start by addressing the overarching pain frameworks that we would consider when thinking about endometriosis and provoked vestibulodynia as persistent pain conditions. And then Helena and Melanie will introduce the conditions with a brief overview of each of them. So I'll hand over to you, Helena.
Thank you very much, Jane, for your kind introduction. And it's been great putting this topic together with Melanie and Jane. We're really looking forward to your comments on it. Hopefully that slide share is okay as we start with the overview of how do we classify these two conditions. So let's start with looking at, can they be classified in any framework that brings them together? So we know that they're both persistent pelvic pain conditions. So if we put them into that big black box of persistent pelvic pain, how do they fit in? Endometriosis is a condition that is, if it's diagnosed laparoscopically, it is considered a disease condition compared to, for example, a syndrome, a pain syndrome. But not all women with endometriosis have pain. So we have this separate group of endometriosis, no pain. They may be completely asymptomatic, or they may be presenting mainly with infertility. However, not everybody who is goes to laparoscopy for potential diagnosis of endometriosis has macroscopic disease. So those women would then be classified as persistent pelvic pain, no endometriosis. There's another group that may have the endometriosis diagnosed laparoscopically, however, that does not seem to match with their pain presentation. And we know that pain and extent or severity of endometriosis disease do not correlate well. So there's this other group that may have the diagnosis, but we're not really sure if their pain is related to the disease. And we also have vulvodynia as another persistent pelvic pain condition. All of these can overlap, and so you can see those circles overlap a little bit and may be comorbid. If we look at the current International Association Study of Pain classification framework for all chronic pain, that's divided into conditions that could be classified as a chronic primary pain or a chronic secondary pain. Chronic primary pains may include other parts of the body, but for this topic, we're quite interested in the visceral and musculoskeletal pain conditions in the pelvis. Similarly, chronic secondary pain, we can see in fact that many pelvic pain conditions could fall into this second category of cancer-related, post-surgical, post-traumatic, neuropathic, visceral or musculoskeletal pain. So we can see with our endometriosis and PVD conditions, they may appear as a chronic primary pain or a chronic secondary pain. Further, we have a group of 10 conditions that have been identified as commonly co-occurring, and these are called the chronic overlapping pain conditions, or COPCs. There are 10 of them, and we can see that endometriosis and vulvodynia are 2 of these 10. And in fact, 4 of these 10 occur in the pelvis. And as we look in a minute at cross-sensitization, this might start to explain some of these comorbidities. So a very quick overview of what is endometriosis, the condition or the disease. It's considered a chronic neuroendocrine immune system disease in which endometrial tissue is found outside of the uterus where it should not be. It has a prevalence of about 11%, and it is the leading cause of chronic pelvic pain in women. So looking at that big black box we started with of all chronic pelvic pains, the majority present with endometriosis or endometriosis associated. Most women develop symptoms quite young. And as I mentioned before, not everybody who looks as if they may have endometriosis turns out to have endometriosis, and therefore they continue to have ongoing pelvic pain. I'll now hand over to Melanie.
Thank you very much to both of you. So I will talk, during my presentation, I will talk about vulvodynia. So vulvodynia has been defined by leading societies as a chronic vulvar pain. Can you just progress for me, Elena? So it has been defined as a vulvar pain of at least 3 months duration without clear identifiable cause, which may have potential associated factors, and a prevalence that range from 8 to 21%. And for reasons that are still unknown, the incidence it appears to be increasing. And we can further categorize vulvodynia as generalized, so if it's everywhere located on the vulva, or localized at specific area like the vestibule, or mixed, so the combination of the two. The pain can be provoked, so when it occurs when we touch the area, unprovoked or spontaneous, or mixed pain, which again is the combination of the two. The onset can be primary, so the pain is present with the very first tampon insertion or vaginal penetration, or the pain can be secondary, which is the pain that occurs after a period of pain-free vaginal intercourse. So we can further describe the pain pattern by describing the temporal pattern. So during my presentation, I will mainly talk about localized provoked vestibulodynia. So this is this was previously called vestibulitis. So I would focus my presentation on this condition because this is the condition for which we have the highest level of evidence.
Fabulous. I am wondering, Helena and Melanie, can you explain what are some of the contributing factors to each of these conditions? What do we know about the conditions, and how do our typical patients present with endo or provoked vestibulodynia? So if we could see how they are similar and maybe how they are different, that would be great.
Thanks, Jane. Yes, it's important to consider endometriosis from this point on as a pain condition, because as physiotherapists, we're not actually treating the disease, the macroscopic lesions. So we're treating the pain that the patient is presenting with, or quality of life or functional impacts. So when we start to focus on the pain, it's quite a complex picture. It is in terms of nervous system innervation, we have both visceral and somatic. Looking at the visceral pain pathways, this schematic diagram divides the visceral afferents from the viscera, the upper pelvic viscera above that pelvic pain line. They travel to the spinal cord segments with the sympathetic nerves, compared to the visceral afferents from the lower pelvic viscera, such as the cervix and the vagina. They travel with the parasympathetic nerves. So already here we can see that we're covering both thoracic and sacral nerve spinal cord segments. And if we look at this more anatomically schematic diagram, we can see these pathways, motor and sensory, to the thoracic and sacral segments. And of course, we then have our somatic nerve supply as well, going to S2-4. So already we can see there's complexity from visceral and somatic nerve supply. I mentioned before that there are comorbid pelvic pain conditions, and this may be explained by the viscero-viscero cross-sensitization and the viscerosomatic convergence that occurs between visceral and somatic structures, particularly in the pelvis. And we need to put that together with what we know about peripheral and central sensitization. I'm very fortunate to be part of an endometriosis research group here in Melbourne, and we've recently published this review paper looking at peripheral, central and cross-sensitization in endometriosis-associated pain and the comorbid pain syndromes, as we recognise these often co-occur. So this paper has a good overview of that topic. However, we know there's much more to pelvic pain than just the biological perspective. So we really need to consider the biological and the psychosocial contributing factors. This recent review by Vincent and Evans tries to group these factors according to whether they're predisposing, precipitating, or perpetuating for the pain presentation. The biological factors are in the red circle, and we would not be surprised to see this group of biological factors that would predispose a woman to persistent pelvic pain. These factors listed are ones that have some evidence related to pelvic pain, but not all to endometriosis, with the exception of the factor endometriosis as a disease. From the psychosocial contributing factors, there has been some observations that link adverse childhood experiences, socioeconomic background, and cultural background and beliefs to be a predisposing contributing factor. We've actually got no documentation of either bio or psychosocial contributing factors as a precipitating event for chronic pelvic pain. But when we look at perpetuating these factors, similar to the predisposing, with the addition of sleep disorders and dietary factors, have been associated with chronic pelvic pain presentations. And for the psychosocial contributing factors, we need to be aware of stress, high pain catastrophizing, depression, anxiety, cultural backgrounds and beliefs. So these are factors that have been associations made in the literature. What do we as a physiotherapist see when a patient presents with endometriosis pain-associated condition? Predominantly, it will appear as an abdominopelvic pain condition more so than a perineal condition, which will be a contrast with PVD. The most common symptoms are cyclic or acyclical pain, so related to periods, pain during or after sexual activity, bladder and bowel function. And we know that there is a significant impact on function and quality of life in common with many chronic pain conditions. Endometriosis and endometriosis-associated pain has been associated with central sensitization syndromes and linked with depressed mood, anxiety, pain catastrophizing, pain anticipation, and increased attention to pain. So we do have these associations reported in the literature. I shall hand over to Melanie now.
Thank you very much. So before going through the contributing factor, provoked vestibulodynia is usually present as the leading cause of vulvodynia, and it can affect women of all ages. It is more prevalent in women below 34 years old. Typically, 50% of them never sought treatment, and only 1.4% of them had been diagnosed. So this is the situation that seems to be occurring in North America and perhaps also in Australia. I don't have the data for this one. So the contributing factor, you will see that it's really similar to what Elena just presented, because they are biological, psychological, and social factor. Regarding the biological factor, it seems that there's some genetic predisposition. There's also some hormonal factors that are related to vestibulodynia. For example, it has been suggested that there might be some androgen receptors that can interact with when they take some oral contraceptive in a subgroup of women, which would sensitize the mucosa and result in provoked vestibulodynia. So that will be the case for a subgroup of women. There's also a pro-inflammation mediator that were shown to increase the innervation of the vulvar vestibule, so which could be related with allodynia and pain, the provoked pain that the women are reporting. And I will talk to you a little bit more with more detail for the pelvic floor muscles and the neurological factor. But regarding the psychological factor, you see that these are the same psychological factor that Elena just mentioned. So provoked vestibulodynia has been associated with fear of pain, catastrophization, anxiety, which is really interesting because they, in a longitudinal study, they showed that anxiety was related to the persistent over 7 years of provoked vestibulodynia. It has also been associated with depressive symptoms. For the social factor, this is a new area, new data that we have from Sophie Bergeron and Natalie Rosen. They showed that when the male partner response is influencing the women's pain and sexual function, but they also mutually are influencing themselves, because anxiety and depression of both partners are related to sexual distress in both partners. So there is like an inter-influence of these social factors in provoked vestibulodynia. There's numerous studies showing the contribution of the pelvic floor muscle. So, for example, with palpation, there are some studies showing increased tone, higher muscle tenderness assessed with a pulpometer, and also the muscle sensitivity has been, this is really interesting, muscle sensitivity has been associated with pain during intercourse, but the mucosal sensitivity was not associated. So this is supporting the importance of the muscle. We have also data with transperineal ultrasound showing some reduction in the hiatal dimension, suggesting an increase in tone. And also going in the same direction, we have some data with myotonometry demonstrating higher stiffness of the superficial pelvic floor muscles. And finally, we have some data regarding the dynamometry showing that there's increased tone stiffness in both the active and the passive component, and also some deficit in the contractile properties. What is really interesting is the later study that we did, we showed that the pain intensity that the women experienced during intercourse was associated with the muscle factor. So this is further supporting the relevance of the pelvic floor. As Elena mentioned, there's the phenomenon of central sensitization. So there's several demonstration of this potential involvement of central sensitization. So women with PVD were shown to be more sensitive in other areas than the genital region, the co-occurrence with other pain conditions that Elena mentioned. And there's also a study by Greenberg. They showed that the deficit in pain inhibitory mechanism as assessed with conditioned pain modulation. So this is a neurophysiological test. And they showed some deficit in women with provoked vestibulodynia compared to controls. And these deficits were associated with muscle tenderness. So once again, it's the central sensitization. It seems to be related to the muscle in some ways, in some mechanisms that are still unknown. I'll stop sharing.
So there seems to be quite a lot of overlap between these similarities and differences between the conditions. I'm wondering if you can, based on some of these similarities and differences, compare and contrast then how we should go about assessing each of these conditions in terms of patient symptoms and a clinical assessment to work out what's going on.
Yes, thank you, Jane. And I'm sorry, now we're on the right slide. So when we assess a patient with endometriosis, what are we assessing? Are we assessing predominantly pain, function, quality of life? So if we're looking at a pain assessment, which pain outcome measure to use? Fortunately, we have some recent publications that give us guidance on this. A group has just published what they consider is a core outcome set. So anybody who is treating a patient with endometriosis or doing research in this area should collect these data. So to measure overall pain, improvement in the most troublesome symptom, and quality of life. Now, this most troublesome symptom is quite interesting because it may vary. So for some women, their most troublesome symptom will be sexual activity. For others, it will be bladder or bowel. So we must capture what is the most important for them. If we're not sure that it is endometriosis, then we can be guided by the guidelines just published on female chronic pelvic pain. As we can see, they're very similar. So in fact, does it actually matter what the condition is, or should we be collecting core outcome sets on chronic pain that are relevant to all of our patients? If chronic pain is the main outcome that we're looking at, we have wonderful guidance from the IASP in exactly what we should be recording and the scales that we should be using for these outcomes. So this document will give you all of the information needed for that. Melanie demonstrated quite a lot of good data that has shown an association between pelvic floor muscle dysfunction and PVD. We don't have nearly that much data in endometriosis. So our assessment will, of course, be much broader than just pelvic floor muscles, but because of time constraints, I'm going to focus just on pelvic floor muscle on this slide. So we're really looking for, is there a pelvic floor muscle dysfunction present in women? Do they have signs of tenderness? Is that corroborated with increased pressure pain thresholds using algometry? Is there increased resting tone or poor ability to contract or relax? Now, we have very few studies giving data on this that are specific to endometriosis, and have a comparison group, because without that asymptomatic comparison group, we don't really know if our findings are representing abnormal. As Beth referred to before, we have a great degree of uncertainty in this, so it's very important that we make these interpretations of our clinical findings based on whether we really think this is a dysfunction. So in fact, in endometriosis specific populations, we really only have 2 studies that have compared resting tone in pelvic floor muscles between women with and without endometriosis. Using digital muscle testing, one study found that there was an increase in tone, and using ultrasound imaging, that there was a reduction in levator hiatal area, which would be a proxy measure of increased tone. In terms of what is the association between the tone in the pelvic floor muscle and the pelvic pain that the women are complaining of, are they associated? We've got some variability in findings on this question and very few studies overall, as you can see. That association was found to be positive when tested with digital muscle testing, but negative or uncertain with very small clinical signs with more rigorous objective tools. So we need a lot more data on this. And across all the studies, we can see that the assessment techniques vary significantly and are quite poorly defined. Again, back to the point Beth just made about the importance of being very specific about the term that we're using and how we are actually performing the technique. And overall, we're really interested in, is anything in the pelvic floor muscle associated to the patient's endometriosis pelvic pain? They may not be. We need a lot more data on this. And this is actually one of the studies that we're doing in our current research. We hope to have the answer to these questions on this slide in about 5 years. Over to you, Melanie.
So it's going in the same direction for the assessment of provoked vestibulodynia. We have some recommendations specific for vulvodynia clinical trial, but you will see the similarity because these were based on the impact, which is similar group for assessing chronic pain. So they recommend using pain intensity, assessing pain quality, physical function. So for provoked vestibulodynia, sexual function, sexual satisfaction, sexual distress are very relevant. They also recommend assessing emotional function, so depression, anxiety, catastrophizing, pain anxiety, as well as assessing perceived improvement, satisfaction, and adverse effect. And there's also some physiological measure that we can add, like algometry to assess the vulvar sensitivity and also to assess muscle tenderness. And we can, of course, assess all the pelvic floor muscle functioning, like Elena and Beth talked to you today early about. So that would be another tool that will be useful. So over to you.
So it's really clear that the pelvic floor seems to be a common problem across these 2 conditions, which is really interesting. And with that in mind, I'm sure there's also differences in the way that you manage these conditions. So I'm wondering if you can both sort of explore some of the conservative therapy treatment options that's available for each condition and some of the evidence that supports some of these different treatment options.
Yes, that's really the crux of it. Thanks, Jane. So this is where we perhaps diverge the most between the 2 conditions. So we have far less evidence for the effectiveness of conservative therapy treatments in women who present with endometriosis-associated pelvic pain. This field of research is a long way behind, maybe because the focus in the past has been endometriosis, the disease. So most of the treatments with evidence relate to surgical or pharmacological. And in fact, if we look at what guidelines say, very little. So the NICE 2017 guidelines suggest a multidisciplinary pain management service, but there's no mention of physiotherapy or exercise at all. And in fact, the ESHRE 2014 guidelines, they're about to be updated, but this current set of guidelines has no recommendations at all for what they call complementary and alternative treatment options. So anything that's not surgical or not hormonal, they have nothing to say. So we really don't have much in terms of guidelines from international bodies. However, we do have some systematic reviews. None included meta-analyses, but if we look at systematic reviews on any conservative therapy, we do have a recent systematic review from Denmark on exercise, any type of exercise. That systematic review included only 2 RCTs, and they provided no evidence of benefit on pain for women with endometriosis. Another systematic review grouped psychological and mind-body therapies together. The body therapy, the physical therapy part included yoga. Only 3 RCTs in this systematic review, very little evidence of benefit. They commented that they appear promising to treat endometriosis-related pain, but very minimal clinical effect. In terms of another systematic review, similar therapies included, and of these complementary therapies, only acupuncture provided effectiveness for pain from 4 RCTs. So that doesn't give us an awful lot of evidence. In preparation for this talk, I undertook a rapid systematic search of 5 databases, and I was assisted by a medical student, which was great. We identified only 3 additional RCTs that have investigated conservative therapies for this particular population. One showed that pelvic floor physiotherapy reduced the levator hiatal area as a surrogate measure of increased tone and showed a reduction in pain. A second one looked at, was there an additional benefit of adding electrotherapy to hormonal treatment, and that seemed to show a benefit, and an indication of improvement from pulsed high-intensity laser therapy compared to sham laser therapy delivered across the abdominal area to reduce pain. These 3 RCTs have very small numbers, and we really need a lot more data to provide firm evidence. In terms of what's going on, I did a quick search on registered clinical trials, and there are a couple emerging in this area. Overall, when we have such a lack of evidence from research findings, what do we say to patients? How do we manage them? We need to go back to our model for evidence-based clinical decision-making, where we consider all 3 contributing factors: clinical state, research evidence, and patients' preferences and actions. So we need to balance these. However, it's often a trade-off. If we don't have research evidence that, for example, massage or a particular type of pelvic floor exercise helps, we need to present that lack of evidence to the patient and be guided by our findings. And it's really important that we document this well and that we're very clear and transparent with our patients with the lack of evidence that we currently have. So we look forward to more evidence in this area.
So we have more data for provoked vestibulodynia. We have studies, RCTs assessing multimodal physio. So physiotherapy, including education, manual technique, biofeedback, insertion technique, and home exercises. We conducted a RCT involving 212 women with provoked vestibulodynia, comparing physio to topical lidocaine. And it's interesting really to emphasize that it's not only muscle oriented, because we also included a more biopsychosocial approach, including the muscle manual technique, but also education, partner involvement, vestibule desensitization. So we had a large component in our treatment about that. And what we found in this particular RCT is that the physio was found to be more effective than lidocaine at post-treatment, and the benefit were maintained at 6-month follow-up. And we also found the same result regarding pain quality, sexual function, sexual distress, pain catastrophizing, and pain anxiety. So physio was found superior, and the benefit were maintained at 6 months. we have also now the recently published study by Marcela Bardin. She conducted the RCT comparing physiotherapy plus amitriptyline versus amitriptyline alone. They performed 8 weekly sessions. It was manual technique and pelvic floor muscle exercises. And what is interesting is that they find significantly higher change in the physiotherapy group combined with amitriptyline versus amitriptyline alone. And they found that for pain intensity with the Q-tip test, the Friedrich criteria, the pain intensity during intercourse, and they also found that with the same superiority for physiotherapy when using 3D transperineal ultrasound. They found that the physiotherapy group had a lot increased anteroposterior diameter, suggesting a reduction in muscle tone. It's also interesting to look into other isolated approaches like pelvic floor muscle exercises to learn how to control the muscle. It was shown that that in prospective and in a randomized controlled trial, a reduction in pain in women with provoked vestibulodynia with biofeedback. So it was the original protocol from Glaser, published in '95. There's also the study of Marcela Bardin showing that women with provoked vestibulodynia, they have a restriction in blood flow. And from the study of Joanie Mercier, she showed that when we are doing some contraction, it is helping it is improving the blood circulation in women with genitourinary syndrome of menopause. Another study that we have that is interesting is the effect of manual therapy on the improvement of the endogenous pain inhibitory capacity. So it seems that the manual therapy, if we apply this to the muscle, it has a centralized effect. So similar to the treatment of endometriosis, we have also the data for pain education, educational videos. So that is more educational, and they showed in prospective studies significant effect on sexual function and pain. There are numerous studies showing the effect of cognitive behavioral therapy for provoked vestibulodynia. The Sophie Bergeron group assessed individual CBT, couple-based CBT, and it was found more effective. They also conducted, Laurie Breton also conducted a non-inferiority study comparing CBT to mindfulness CBT, and it was shown to be non-inferior. Just to remind what Elena just said, it seems that in chronic pain condition, there's a benefit of doing physical activity. It helps, and this with the data that I'm presenting here, it's not related to provoked vestibulodynia. It is in a population of chronic pain condition. But I find interesting to raise this point that we don't have the data yet for provoked vestibulodynia, but it's likely that they may respond similarly because physical exercise improve mental health, reduce depression, increase the production of endogenous opioid, and it is also decreasing peripheral and central pain sensitivity. So I would like to conclude on my section regarding physiotherapy. So we have evidence for physiotherapy that it is effective for women with provoked vestibulodynia. We need more research to better understand the mechanism of action and to determine the optimal combination of treatment. So in this way, we will progress to develop more personalized medicine to propose adapted treatment to each women according to their contributing factor. Thank you.
And Helena, I just wondered, I think Melanie sort of wrapped up with her conclusion. I wondered whether you wanted to sort of finish with your sort of summary of management recommendations for women with endometriosis.
Thanks, Jane. Yes, I tried to include that in the evidence-based practice model slide. So really saying given we have very little guidance from research findings, we need to very carefully integrate what do we know from the clinical state of this condition, the patient preferences, very carefully measure the symptom that the patient reports, document exactly what you're doing, reassess very carefully. So it's more a matter of clear documentation, clinical reasoning, and evidence-based practice approach.
Yeah, fabulous. We might have just a minute or two for a couple of quick questions, and probably one, Helena, that's directed at you that relates to what you've just spoken about is Joanne Cecile Sabarin. Sorry, I'm not great with names, but she's asked, can you quickly summarise what else you might assess outside of the pelvic floor and outside of the pelvic floor criteria that you've outlined?
In endometriosis, yes, thanks, Joanne. Because we have very little data as to whether it should be the pelvic floor muscle that we should be focused on, that was, I just took that one aspect. If a woman with endometriosis or endometriosis-associated pelvic pain presents to us, we don't know what the focus needs to be until we take a good history, ask her symptoms, carefully document patient-reported outcome measures, and then you'll be guided by the symptoms and the history as to where your clinical assessment needs to focus. As I said, they will generally present with abdominopelvic pain as the picture, but if there is any report of pain elsewhere in the musculoskeletal system, that will be important to assess. But understanding the nature of the condition and the disease, you would then need to decide, is this relevant, or maybe this may be related to a separate chronic pain condition. Just on that note, actually, no, I'll stop there.
It's always hard to stop talking about it, isn't it? I mean, it's really a very holistic thing that we need to look at. You know, it's not just a pelvic floor problem. I wanted a question from Heather Moki is that she often finds that the psoas is a problem area for people with endometriosis, and whether you had any thoughts on this, Helena?
I'm not aware of any data that has, or any empirical data on that particularly. There are a lot of observational reports of what people have found. I didn't include those because I was looking more at the pointy end of the pyramid of the hierarchy of evidence, where we should try to focus our attention in terms of informing treatment. But as we just discussed in the last question, you need to do a careful assessment and identify what you think is contributing to the patient's problem, whatever that most troublesome symptom is, whatever is contributing to their functional impairment and their health-related quality of life. It may not be related to pelvic floor muscle, but we certainly have data that pelvic floor disorders, bladder and bowel, are frequently comorbid in women with endometriosis. So we should certainly inquire about bladder and bowel function.
Yes, definitely. And maybe a final question for both of you. And I would encourage anyone who's got additional questions to join us in the live lounge afterwards, because I think both of you will join us in the live lounge and you can answer some other questions. But a final question for both of you, and something that I'm really interested in, is the role of pelvic floor down training, because we often think of pelvic floor exercise as being the sort of up training, strengthening. I wondered if you could both comment on, I suppose just the role of down training and the role of that in clinical practice in managing both PBD and endometriosis.
Melanie and I are actually co-supervising a PhD student, and she's investigating this question. So we're interested in it. We know you're interested in it, Jane. So hopefully we'll all start to get a bit more data, because we actually don't have empirical data to guide what is the best way to change abnormal resting tone. So that's a short answer.
I would add to that it's important that the clinicians are not treating vulvodynia or chronic pain as incontinence. Like, it's not like the strength training that we wish to increase strength no matter the relaxation state. So like in my RCT, what we did was contraction, but the focus was also on the relaxation, because we wanted to be sure that we are teaching the woman to contract and also to relax properly. So it was much more a matter of pelvic floor muscle control than regular strength training for incontinence. And I think, Jane, this is a very relevant comment, because in some area they kind of, it seems that there's some mixed up, that they are treating pelvic pain as a strength training, like you want to improve incontinence, and that's not what we've done. And I know that Marcella Bardin, it's not what she did neither.
Yeah, absolutely. And I think it's great that you say it's about that control, because certainly the strength is important, but the relaxation at the other end of the scale is also so important. Yeah. Okay, I think in the interest of time, we need to wrap up. But like I said, please join us in the live lounge, everyone, if you have more questions. And thank you so much, Melanie and Helena. That was fantastic.
Thanks to you, Jane.
Thank you both.
I'd like to take this next opportunity to introduce our final speakers of the session, and thank you everybody for all the wonderful lectures we've had. I would like to start by introducing Laura Burchell and Dr. Schechter. Laura has been specializing in pelvic floor physical therapy both in the United States and Australia for over the past 15 years. And between 2016 and 2018, Laura established one of the world's first and largest physical therapy programs for trans people of diverse genders, seeking gender-affirming surgery in the United States at Oregon Health and Science University. In doing so, Laura highlighted the central importance of physical therapy-led preparations and recovery following gender affirmation surgery. The program has expanded in recent years to include more physical therapists working in the clinic. Working in this community reinforced for Laura the importance of physical function for identity, self-expression, and quality of life. Laura holds physical therapy registrations both in the United States and Australia, and since returning to Australia, she continues to see trans people of diverse genders in the public and private settings. Laura is a senior clinician at the Royal Women's Hospital in Victoria, Australia, working in pelvic, vulvar pain, and sexual dysfunction clinics. And then also I'm going to introduce Dr. Schechter, who received his medical degree with honors from the University of Chicago Pritzker School of Medicine and completed his residency in general and plastic surgery, as well as a fellowship in reconstructive microsurgery at the University of Chicago Hospitals. Dr. Schechter is an attending surgeon at Rush University Medical Center in Chicago, USA, and the director of the Center for Gender Confirming Surgery at Weiss Memorial Hospital. He serves on the executive committee of the World Professional Association for Transgender Health and has helped to author the 7th edition of the Standards of Care and serves as co-lead for the surgery and post-care sections for the 8th edition. He's authored the first surgical atlas concerning surgical management of transgender individuals and is a founding member and president-elect of the American Society for Gender Surgeons. We're very lucky to have both these speakers here tonight, and I'm going to turn this over to Dr. Schechter.
Thank you very much, Heather, and it's a real pleasure and honor to meet and speak with you today. What I'd like to do in the time that we have, about 8 minutes or so, is really introduce several concepts and use that as a stepping point for discussion. As Heather said, I am the treasurer and serve on the executive committee of WPATH, and I hope that each of you have an interest in this topic will consider joining the organization. The role of physical therapy, occupational therapy, speech therapy is recognized as been increasingly important. I don't think I need to emphasize, especially to this group, that care is really provided in a multidisciplinary format. However, I think what we've recognized over the years, and I've been in practice for over 20 years and performing gender affirming surgery is that our concept of multidisciplinary has really changed. And I've highlighted that to say that it's a collaborative effort, not only between the physician or the professional who's prescribing hormones, the mental health and behavioral health professional, but the surgical team. And the rehabilitation specialists, including physical therapy, occupational therapy, speech therapy, have become increasingly important and integrated in the team. Our pelvic floor physical therapist, and let me thank her, Tracy Alvarez here in Chicago, is in our clinic. She sees patients preoperatively with me and also sees patients postoperatively with me and independently for issues related to dilation, pelvic floor related concerns, and so forth. So we know that gender affirming and gender confirming surgery, by helping to align the body with the identity, not only help to relieve gender dysphoria, but also improve quality of life. And also, I should say, reduce negative health outcomes. But these benefits and the improvement in quality of life also come with an improvement in sexual satisfaction. And I'm going to speak about that in a minute. We know that the rates of postoperative satisfaction are high, and that's even in the face of complications. And I'm going to focus mostly on complications in this talk. I do think it's important to recognize, though, that complications regarding genital gender affirming surgery are commensurate with the complication rates of other genitourinary reconstructive procedures, for example, following oncologic or cancer reconstruction, birth-related conditions, and traumatic reconstruction. Now, complications following vaginoplasty are high, and that's if we're being truthful and honest in how we report them. However, most of these complications are minor and self-limited and are typically treated in the office and on an outpatient basis, most often with local wound care. Some of the, and probably the most dreaded complication, rectovaginal fistula, is quite uncommon. The rates vary a bit by study, but in the hands of experienced surgeons should really be well under 1%. Now, how do we predict complications preoperatively? Well, there are some physical or medical conditions that may increase the risk of complications. Weight and BMI is a rather controversial topic. And while there may be no direct link between weight and BMI with complications, let me just raise a couple of important points, especially when we're counseling patients prior to surgery. So for individuals who are obese and morbidly obese, and in the United States, obesity is a problem, the ability to access one's genitalia can be difficult, meaning the ability to physically insert the dilator can be challenging. There may be some linkage between complications such as venous thromboembolism, but there may be other issues, rather practical issues, such as relative tissue deficiencies. So although the size of the phallus and scrotum may be normal, there may be a relative tissue deficiency, such as a case with a buried penis. Medical conditions such as diabetes and other comorbid medical conditions may also increase the risk of complications, certainly previous surgery, pelvic radiation, etc., and smoking. In my practice, we don't perform vaginoplasty on smokers. We do check for urine nicotine and cotinine, and we do require smoking cessation prior to surgery and through the postoperative period. But let me also highlight a problem, and that's the issue of compliance. I don't mean compliance in the sense of the patient not listening to us, but the many factors that may go into their ability to adhere to various postoperative regimens, such as the need to return to work and the ability or the accommodations that one's work or job may provide for them to dilate, a quiet, a private place, the time and space to do that. And those are some of the issues that I'll highlight shortly. But what are some of the other factors that may affect satisfaction and also increase the risk of complications? Social relationships, whether someone has a partner, is sexually active, enjoys or engages in a sexually fulfilling life prior to surgery, how their transition has been accepted by their family, friends, and their direct environment. Have they lost social contacts or professional opportunities due to their transition? And individuals who report feeling lonelier overall. And again, this gets back to and stresses the importance of that multidisciplinary approach. But once again, that multidisciplinary approach has to be expanded. Again, it's not simply physicians or allied health professionals. That may include social workers, marriage and family therapists, sex therapists, and physical therapists intimately working and related with the surgeon. Now, while transgender women consistently report significantly higher levels of satisfaction with their sexual experiences following surgery, as the movie suggests, it's complicated. So what are some of the challenges associated with sexual function? Well, as I said before, poor sexual function, and this I believe is true in my practice and how I counsel patients, poor sexual function or lack of sexual function and orgasmia, for example, I believe is significantly correlated with the ability to orgasm following surgery. So for individuals who are orgasmic and sexually active prior to surgery, I think for the vast majority, almost all individuals are able to orgasm following surgery. We also have to recognize, however, especially for adolescents, that following vaginoplasty, this may be the first opportunity to experience sexual pleasure. It's important to note a trauma-informed approach, whether one has a history, the individual has a history of physical trauma, emotional, mental trauma, and or abuse, whether physical and or sexual abuse. This all plays into the ability to, in my opinion, effectively dilate following surgery. And of course, as we said, medical conditions, medications, depression, anxiety, substance abuse may all have an impact on one's sexual function. So what happens if there is a problem following vaginoplasty? And by that, I'm really referring to stenosis. We'll leave aside rectovaginal fistula for a bit. But significant vaginal stenosis may occur in up to about 15% of individuals. And as you all well know, this may occur in association with pelvic floor dysfunction. So our job for those individuals seeking secondary or revision surgery is to restore vaginal lining and promote pelvic floor function. In terms of vaginal lining, we need to make an assessment as to how much, the quantity of lining, as well as the location. So perhaps stenosis is a more straightforward introital stenosis that may be handled with a little scar revision. Perhaps it's more significant and relates to complete loss of the vaginal canal. And these conditions, as I'll show you in a moment, require different treatments. We have three basic tissue types that we use for vaginal lining. Far and away, and certainly for primary vaginoplasty, skin remains the mainstay with the traditional penile inversion vaginoplasty. Colon vaginoplasty, typically with sigmoid colon, is another option, and in my practice is typically reserved now for individuals with complete loss of the vaginal canal and or rectovaginal fistula. And finally, peritoneal tissue, which may be used in conjunction with skin grafts, may be used as either a primary approach or a secondary approach. Each of these tissue types has certain advantages and disadvantages in terms of their inherent qualities, the ability to provide moisture, distensibility, etc., but also in terms of the donor site and risks of donor site. Of course, scarring from the need to harvest skin grafts, the risk of an intra-abdominal surgery with either the intestinal or peritoneal approaches. So surgery is certainly important for those individuals seeking revision surgery, especially for significant loss of the vaginal canal. But I would argue physical therapy, both prior to revision surgery, so preoperatively and postoperatively, is equally important. This may relate to physical conditions such as the pelvic floor, but also psychological assistance. So an assessment is the need, should the etiology of stenosis been one of lack of dilation? Why was that? What are some of the inhibitory factors or things that we may change or be able to influence prior to surgery? The ability to instill confidence in inserting a dilator, sense of control, and so forth. Very briefly, when we assess from a surgical perspective revision vaginoplasty, we're really looking, as we said earlier, at vaginal lining, but also on the dissection of the vaginal canal. So not only is lining important, but we typically have to release the levator muscles to achieve adequate both width and depth. Of course, revision surgery carries with it risks of pelvic muscle dysfunction, injury or trauma to the pudendal nerve, and then, of course, secondary sexual and/or psychological concerns. Thank you very much, and I appreciate the opportunity to present.
I'm just trying to share my screen here. Why is it not? Sorry, give me a minute. Here we go. Thank you very much. Thank you, Heather, for the introduction. And I seem to have now, well, we'll have a screen within a screen, I guess. I just wanted to acknowledge the First People of Australia, the Kulin Nations in which I stand, and the elders past, present and emerging, and also those who identify as trans and gender diverse. You might be watching here, and certainly your lived experience is one that I learn from each day. I have no disclosures. And I think what's most important, yes, so I might just try and share again. No, it's not. Why is it not letting me do that? Sorry, I'm going to need some technical support here. Here we go. Yeah. How's that? Is it looking better? All right. Thank you for that. Sorry about that technical glitch. I think the last 10 years have shown a dramatic increase in the number of patients globally coming to seeking assistance for their trans affirmation, both hormonal and surgical, and that has really resulted in a lot of research now happening in this space. The thing that mostly guides my care in the work that I do are the guidelines set by WPATH, of which Lauren is an executive committee member. And I really recommend anyone working in this space or starting to see those who are trans or gender diverse to look at these guidelines, because they are based on clinical evidence or expertise and the best or the most recent research. Some of those foundation courses you can access online. There is a new version being updated and released in December with a couple of new chapters, and certainly I'm looking forward to seeing that of the surgery and the post-op and what that might look for physiotherapy. Yeah, thank you. So the key points for physiotherapy, I think it's really important to understand the journey of affirming one's gender, because it's very individual, that being both social, hormonal or surgical options. And I think that guides our assessment, it guides the questions to ask and helps us address those signs and symptoms. Here in Australia, we tend to use the word affirming one's gender. I know if you look at the literature, and you'll see more gender reassignment surgery. And I see predominantly in clinical practice those who are seeking or have had a vaginoplasty for pelvic floor dysfunction or dilator therapy, and this new and emerging group of those on testosterone and pelvic pain. But due to the time, I will only focus, and to complement Lauren's presentation, I'm just going to focus on the feminizing affirmation. So why is there a role for physiotherapy? Well, we know with the penile inversion technique for creating the neovagina, it requires dissection through the retroprosthetic fascia, and I know Lauren can speak more to that procedure, but we know that there is involvement in incision of puborectalis, and we know how important puborectalis is for bowel function and pelvic floor and bladder and bowel, as well as sexual function, part of the levator ani. So what is there in terms of research in this space? Well, it's evolving, and I think the first part was that Sandy and I started seeing patients in 2016, and really we were aiming to describe the patient group, and we found that 42% had pelvic floor dysfunction or disorders of dyssynergia, control, contraction, and relaxation, and many also had bowel dysfunction, poor emptying technique, and constipation. Surprisingly, or perhaps not surprisingly, if we understand the patient population, that there was a high rate of sexual abuse disclosed in this group, and that was much higher of significance before, with preoperative pelvic floor dysfunction. Like Lauren said, I think it's really important to reach out and have a team to look after and treat these patients, and looking for patients that can connect with psychologists that have a trauma-informed approach. I think we also need to be mindful of that and reflect that. And I'm now just jumping quite a long way away. Right, here we go. Goodness me. Thank you. And so we need to make sure that we have got a good team to work in. In the US, I was part of a gender team here. We're in Australia. Most of the surgery occurs privately, and so I'm seeing these patients in a more private setting. What is there in terms of incontinence after vaginoplasty? It's a question I get asked a lot, and a lot of these articles are retrospective, single case series of low numbers, but the group out of Switzerland did look at urinary involvement and incontinence after surgery, and they did find there's a diverted stream, and WPATH does show that or discuss that in its guidelines. There was more of an OAB picture rather than stress urinary incontinence on the King's Health Questionnaire, and there was a minimal or reduced urinary flow. Whilst a digital palpation of the levator ani was not performed, there was perineal ultrasound, and over half of those individuals were unable to isolate or contract the pelvic floor muscles. Interestingly, again, they were not socially disturbed by their urinary issues. We know this from other cisgendered groups. And for many people, many individuals, they've waited a really long time to have this surgery. And so for some people, they feel it's almost inevitable. But I think it's important as physical therapists, because we have got the time, is to find out and discuss those issues and be able to address them. In terms of strength and intervention with the pelvic floor physical therapy, there is an article that's just been released by ICS in the ICS journal earlier this year out of Brazil. It was a small case series of 15 patients, but they did find, or they did use pelvic floor muscle assessment. They used surface EMG, which we know has some confounding factors, but they used some validated questionnaires. And they found a decline in strength and decrease, which perhaps we would see in cisgendered populations after surgery. There was improvement between 15 and 30 days, but urinary incontinence, particularly that urge symptoms, persisted post-operatively, and so did their symptoms of urgency. We know that there is incision and shortening of the urethra, removal of bulbospongiosis, and perhaps some of that urgency is coming from irritation from the dilator. Most of the research in this space, particularly for things of pelvic floor nature and incontinence, they are using standardized questionnaires, but none of these are validated for, validated for the trans or gender population, and most of them are cisgender scales. That is changing, and there was a good multi-center trial out of Europe with 206 patients, and it's reporting on patient-reported outcomes. And these individuals having vaginoplasty, the main issues or themes that they found was they really did want more involvement and appointments post-operatively. They were seeking assistance from their mental health professionals, and we know that currently the WPATH guidelines suggest that we stop or reduce the estrogen before surgery. So it becomes quite an emotional time for these patients, and then they're undergoing a very large procedure, and then there's pain as well. We also need to look at those resilience factors, and I think that Lauren really highlighted that well in his approach, that we need to look at the social understandings, what supports they have, and how are they going to actually do the dilation afterwards. 20% were seeking more intervention and support from the physical therapy team for pelvic floor dysfunction, as well as support for dilator therapy. But if we look at the dilator therapy information and the research, there are no standardized approaches. It varies between centre and centre. It varies from Australia to the US, where we're moving towards the softer silicone dilators, whereas at OHSU, they're using still the firmer silicone dilators. I think we know that the primary goal for a lot of these individuals is for receptive vaginal intercourse. I don't think we can assume that. The stenosis rates were highlighted by Lauren, and that's why we need to be involved from a dilator perspective. But without these standardized approaches, we really need to make sure that the goals for the individual are met in terms of depth and width. In the 77 individuals that we followed, by 3 to 6 months, they had achieved, 80% of them had achieved their desired depth and width of dilator with physical therapy intervention post-operatively. The key points, I think, in this really short talk is to understand the journey of the individual in front of you, understand their social supports, their psychological situation, and make sure they're connected to team members for support from a psychological perspective, from social work perspective. I think the thing that we're seeing is that preoperative involvement is really important. If we can address the dyssynergia, the coordination and the dysfunction before, I think we're helping them in the long term. We're also giving them the opportunity to understand better what dilation is, what a dilator is required for, and helping them set goals for doing that at home or wherever they are. Without more rigorous research in this space, we need to be guided by the patient and have them as the focus of our care. And we need to be guided and use all of the clinical expertise that we have in the cisgendered community, but acknowledging that, that a lot of those questionnaires particularly are for cisgendered populations, and that we're also having an effect of hormones on these muscles that we don't see so much so in the cisgendered community. Thank you very much.
Thank you so much for that talk. It was it was a great overview, and this is such an emerging field. We have a couple questions here, and you both can just kind of fill in with the questions. This is a great question. Is there a role for physio once there is stenosis?
Look, I think a physio, sorry, Lauren, if you're all right for me to.
No, please go ahead.
To answer that. So here in Australia, I'm seeing a lot more patients down the track. And I think we need to be mindful of just how much change we can create and to reach out back to the surgical team. If it's related to dyssynergia or an inability to control or particularly relax the pelvic floor muscles, I think we have a really important role. But one thing, things have quite, there's stenosis and shrinkage. I think we need to reach out to the surgical team, particularly if it's impacting on sexual function, which is, highly desired in this group.
And there's a continuing the question saying, asking from the point of view of a patient where dilation can cause pain and injury.
So let me just say I agree completely with Laura, and I'll put the physical therapy, I will answer it, yes, there is a role for physical therapy in the face of stenosis. Now, as Laura suggested, if there's sort of, it's early in the postoperative period, tissues are still somewhat soft and supple, I think dilation is critical, and a bit more aggressive dilation can salvage the situation. Once that's dense, cicatricial scarring, firm scarring, while it's unlikely that dilation itself may have an impact, I think that gets us back to the issue of why was there stenosis? Was it a healing problem? So was there graft loss or flap loss that okay, that's a surgical issue? Or was it difficulty with dilation in the first place? So we don't want to be back in the same situation following a revision procedure. In either event, I think that the physical therapist can help prepare that individual, assuming they'll go on to revision surgery, for that revision surgery, whether it's psychological, whether it's confidence, whether it's reassurance, or whether it's understanding the physical maneuvers that are involved or required for dilation.
Learning a good technique for inserting the dilator, understanding when the person is able to do it, and I think involving the physical therapist early in that post-op period is paramount.
I will say probably the involvement of the physical therapist has been, there's not a lot that's gone on with surgical technique in terms of advances. I would say the involvement of physical therapy early in the process has probably been the biggest and most significant advancement in the pre and post-operative care for individuals undergoing gender affirming surgery.
We're going to go over to this next question here of, can you comment on why you may reduce the use of pre-op estrogen, and what are the likely adverse events from continuation?
Well, WPATH recommends reduction, and I'll certainly be interested in Lauren's comments here. But here in Australia, it's recommended to reduce in the 2 to 4 weeks before surgery, predominantly because of that thromboembolic event or a DVT. And so the long procedure, the bed rest time, they're the main reasons, and the current guidelines for reduction in estrogen or their hormone therapy.
So Laura is correct. This is an evolving field. I have a review article coming out in plastic and reconstructive surgery. Let me just say it's not the standards of care that necessarily specify the reduction. It's been a practice based on historically what has been an increased risk of venous thromboembolism. However, that tends to be with the ethinyl estrogen preparations. The newer preparations, the bioidentical preparations, do not appear to be associated with a higher risk of venous thromboembolism. The issue of this issue of VTE or deep vein thrombosis, called the silent killer, is always a concern, as Laura said, for many reasons. There are a variety of instruments that we use to assign risk. In plastic surgery, it's the Caprini risk assessment model. Those include risk factors such as bed rest, immobilization, general anesthesia, and hormone use is on there as one point. I think we're recognizing, however, that generally refers to the older ethinyl estrogen preparations. And it appears, and I'm hedging myself, as you can say, because as Laura said, we're extrapolating data from our gynecologic colleagues, et cetera, and those may be shorter procedures, outpatient procedures where people are more ambulatory. But it appears that with the bioidentical preparations, there may not be a higher risk of venous thromboembolism. There's also no standardization, however, in perioperative VTE risk reduction strategies. So mechanical compression, ambulation protocols, chemoprophylaxis vary quite widely.
I think a team here in Australia are also looking at, do we have to reduce the estrogen in that operative time?
Unfortunately, time flies and we're already over our session time. So I'm going to hand this back over to Haley, but thank you both. There are a couple more questions if you wouldn't mind answering or joining us in the live lounge. And we'll look forward to doing another session on this in the future. Thank you.
Thank you.
Thanks, Heather. So that concludes our Physiotherapy Forum. Just wanted to thank again all of our speakers and organising committee. What a success. Thank you also to the speakers, not only for the presentation, but for your years of passion and dedication and hard work that goes behind these. We're all beneficiaries of that work, so thank you. We do look forward to meeting next year in Vienna for our next Physiotherapy Forum, but in the meantime, hopefully we'll catch you all in the live lounge to have an informal chat and to answer more of your questions. Thank you so much for tuning in.